So I, from a very young age, knew I wanted to be a surgeon.
Wow.
This is very interesting. Yeah, my parents swear that as early as 5 or 6 years old, people would ask me what I wanted to do, and I didn't say I wanted to be a doctor. I wanted to be a surgeon. The belief that if you're eating real food and you're only eating plants, that's better than eating real food with meat is, I think at this point, demonstrably false. And I do think that meat is essential to our optimal health.
I think that even though the tide is shifting somewhat, today's population does not want to think the food environment is as bad as it is for their health.
Yeah, I mean, we're definitely, I think, maybe coming to a little bit of a reckoning. And what's really, I think kind of got to me more and more over the years, right, as I was doing heart surgery, and especially became magnified when I went on a low-carb diet because I was overweight, I was pre-diabetic, and I was headed for my own operating table, so to speak.
Tell me who you are and what you do.
Thank you, Dave. Great to be here with you. I am Philip Ovadia. I am a heart surgeon who now is on a mission to keep as many people as possible off the operating table.
Yes, you aren't, a lot of times people think, oh, heart doctor, probably like a cardiologist, but specifically you're a cardiothoracic surgeon.
Correct.
So you get in there.
I get in there. I hold the heart in my hands. I do, the most common operation I do is what's called a coronary artery bypass. So this is when heart disease has reached its very advanced stages, and we don't really have options anymore for things that are a little bit less invasive like stents. We're in there literally redoing the plumbing essentially to deal with blockages that have accumulated, also deal with problems with the valves that can occur in the heart. What I do is a end stage of this disease process. And what I really came to recognize, throughout my 25 year career now is this disease really shouldn't get to that point. It shouldn't need something like that. And the reason that it does so much is because I think we're focused on the wrong things as the cause of the disease, and therefore we're doing a lousy job at preventing it, and we instead need to rely on treating it with these maximally invasive things like heart surgery.
Yeah, this is something I definitely have been looking forward to unpacking with you because, as you know, it's a big focus of my research, but I'm coming a bit more on the lipid side. I go on a low-carb diet, and right up until the point that I'm going on a low-carb diet, I'm like gaining a little extra weight, but I'm looking around at my same class, and seemingly we're all gaining weight, and I seem to be doing better than they are. So my BMI gets up to like maybe 26, which for 10 years ago seemed pretty decent because I had a lot of other friends that were doing a lot worse than I was. And therefore, I like to compare this to smoking a lot. It's like, 60 years ago, I would be the lower smoker.
Yeah.
So I'm not as bad in relative terms to everybody else I know. But definitely more and more I see is what's happening to us with our metabolic health on the outside often reflects what's going on the inside. Would you say that's been your experience?
Yeah, definitely so. And, exactly what you said about heart disease being normal, right? It is the number one killer. It has been now for over 100 years. And it's almost thought of something that's kind of inevitable, and maybe we can do a little bit to slow it down. And, you might die of something else first. But, 25% of people that die of heart disease in this country still. And what's really, I think kind of got to me more and more over the years, right, as I was doing heart surgery, and especially became magnified when I went on a low-carb diet because I was overweight, I was pre-diabetic, and I was headed for my own operating table, so to speak. It just sort of occurred to me, why do we accept that this is still the number one killer? And, maybe kind of how our paths ultimately crossed was, I said, well, if cholesterol is the cause, and we know this, and we have treatments for it, then why are we still here with it being the number one killer? Like, why haven't we had a significant impact? And that is really, I think, the key question that doctors in this field don't ask enough. Like, if we know what causes heart disease, why haven't we fixed it?
Yeah, there was, I was forgetting who it was I was talking to, but they were explaining how in the 70s, it was almost a kind of euphoric revelation that Brown and Goldstein so effectively proved that it was LDL cholesterol, such that this doctor I was talking to, who was considering, becoming a cardiologist, his advanced doctor friend was saying, oh, I don't know that there's much reason for you to go into that. Like, that field's probably going to start going away because we're going to, with these powerful new drugs, we're going to get LDL low enough that it's going to be an orphan disease, and heart disease just isn't going to be a disease of the future. That proved to be wrong, that we're getting quite sophisticated in medicating down LDL levels. So in your opinion, why isn't that working to take away heart disease?
Yeah, that's really the question we need to answer. And, I had the similar experience, right? I was going through the early part of my surgical training and deciding what subspecialty to go into. And I decided I wanted to go into heart surgery. And my mentors told me, absolutely do not do that. You will not have a job. There's going to be nothing for you to do.
You got the same advice.
And I got the same exact advice. This was, 1998, 2000. And here we are. And not only is there not a job for me, there is actually a shortage of heart surgeons in this country now. There are not enough heart surgeons to do all the heart surgery that needs to be done. So it tells you, what has happened during that time. And the question why, right? We should be answering that. We should be asking that first of all. Cholesterol is the cause, is what I was told my entire medical education, my, entire career as a heart surgeon. Cholesterol is the cause. We have gotten better and better, like you said, at treating cholesterol. We can bring those numbers down to extraordinarily low levels, and yet heart disease isn't going away. And, again, what was so interesting when we first met, right, which is now 6-7 years ago.
Yeah.
Doctors and the medical system look at that question and say, well, it's because we don't lower it enough. We don't lower it early enough, right? We need more. And you as an engineer, right, stepped back and said, that can't be true, right?
Well,
the system,
yeah.
Right? We haven't fully explained the system, right? At a minimum, what you could say is, okay, maybe cholesterol is part of the story, but obviously there must be more, because lowering cholesterol does not have the magnitude of impact that you would expect it to if it really was the majority of the story. And so, you have to start asking, right? What else is going on in the system? What else are we missing? And I continue to be amazed today that my colleagues within the, traditional medical space, they don't ask that question. The only thing, when I ask them, right, I confront them, I say, why is this patient on my operating table when they've been taking medications to lower their cholesterol for 20 years and they're within the guidelines? And all they say is, well, I guess we should have started it earlier, or we need the more powerful medications to lower it even more. And they literally cannot fathom that there must be other stuff going on that we haven't accounted for.
Yeah, there's this, I'm not sure if this is a real fallacy per se. I think it's an offshoot of the no true Scotsman fallacy, but I like to call it the preacher's fallacy, which is when you see the example of some fringe church where the preacher says, hey, I can heal anything. So long as the whole room believes strongly enough, I can make, this person walk or something. Okay, I'm going to try. Okay, is everyone in the room focused? Okay, because you've got to believe strongly enough. Oh, it didn't work. You guys weren't believing strongly. I need the whole room to feel. So it's something that cannot be effectively quantified enough. But at the time I was getting into this space, there wasn't PCSK9 inhibitors. Now you actually have a drug complement that can get like practically all the way down to zero. And so you would think that that would be easily the trials that would yield effectively cardiovascular disease risk-free populations in the intervention group. But we don't see it there either. We see what they would consider to be a strong efficacy, but it doesn't actually just eliminate the heart disease or the progression of the heart disease. But getting back to what you're describing as the questions that I, of course, want to ask everybody, but particularly people are into heart surgery, is, okay, why is it such a small effect size, assuming that we're acknowledging together that it is a component of atherosclerosis? If it's the central driver, why aren't things like PCSK9 drugs at just doing what we thought Brown and Goldstein were taking us in the direction of, practically taking it entirely out of the equation?
Yeah, it's a great, well, I mean, we know the answer, right? But getting that message out is so important. And, what's interesting is doctors, right, when you go to the kind of the larger doctor community, there'll be this acknowledgement. They'll be like, well, yeah, of course, cholesterol isn't everything, right? We know there are other things. But in practice, they don't implement that. They don't pay attention to the other stuff, right? They'll be, okay, stop smoking, great, right? But, you get to things like insulin resistance that we know are so important, and they ignore it. They don't measure it. They don't look at it. Maybe there's starting to be a little acknowledgement in a roundabout way because we have these things called GLP-1 medications that sort of affect insulin resistance. And yeah, they also reduce heart disease. And oh, by the way, they don't actually reduce cholesterol. They might raise it, but somehow it's still helping heart disease. And somehow this all still makes sense, right? You get into this roundabout thing, but in the end, it comes back over and over again to the cholesterol question. And you're right, the PCSK9 inhibitors, right? These should be the proof, right? If it was all about cholesterol, we should see massive reductions. And, we see reduction, but I would say it's nowhere on the scale that it should be, right? If this was the story. And we then start to see the trade-offs for those reductions, right? Because I've seen the patients with their LDLs in the single digits, and there's some stuff going on that can be very concerning. And overall in the trials, you're like, great, we reduce cardiovascular disease by 40%, but patients don't live any longer. And they might actually live a little shorter, depending on which trials you're looking at. And then you're like, okay, well, what's going on there? But again, this is part of, I think, the problem with the medical system as a whole is it's not the cardiologist's concern whether you die of something else. It's only their concern whether you die of heart disease. So they're like, well, great, I reduced it 40%, my job is done. And you're like, well, but the patient feels miserable and isn't going to live any longer. And you kind of get stuck there, right? Because they're like, well, not my problem, which is another interesting part of our medical system these days.
It's a bit of an issue that I am obviously very passionate about. I mean, the very first question I jumped to when my cholesterol skyrocketed 10 years ago was, okay, I do see data that shows there is this association between LDL levels and cardiovascular disease. Okay, but that's one way of dying. That's one way of affecting, possibly health span, maybe, right? But what about all non-cardiovascular disease related outcomes? Are they unaffected? Do they, or are they affected? Well, associational data should at least give us a quick gut check. And if low LDL does not have any trade-off, presumably, the people who do have, like, say, genetic abnormalities where they have lifelong low LDL will just live longer. They'll live longer than all of us. And that's the one question that I've asked a lot of people who are in favor of lowering LDL. Why aren't you interested in this data as much as I am? Because 10 years ago, when I was trying to find anything on this, I could not find anything that suggested that no, those people with lifelong low LDL do in fact live longer than the rest of us.
And again, I would say we have pretty good data on that right now. You know, we have the PCSK9 loss of function. We can even look at as much as I hate to say it, the Mendelian randomization studies, right? And they show exactly the opposite. They don't live longer, and they may actually live a little shorter, you know, depending on which study you're looking at. And, you know, you're exactly right, again, but that question doesn't get asked within the medical system. The way that the medical system has evolved is such that, you know, the people that are focused on heart disease are only focused on heart disease. And this is another question about cholesterol, right, that now goes through my mind. And admittedly, 10 years ago, 15 years ago, I wasn't thinking about this. I wasn't asking these questions, right? I was a heart surgeon. My job was to take care of heart disease. And, you know, we did what we had to do for that. But, you know, cholesterol as a whole, right, what else is it there for? What else is it doing, right, within our bodies? And if we're focused on lowering it, right, what are those other effects that we're going to have? And, you know, even going back right to the statin data, you should be able, if heart disease is the number one killer and statins are okay, we'll call it, you know, moderately effective at reducing heart disease, well, then we should be able to easily demonstrate that people taking these medications live longer. And again, you don't. You can't. So those are questions we definitely need to, you know, get more into the mainstream, right? And it's so interesting within this community, right, within the low-carb metabolic health community, that people do talk about this and people do think about it. And we, you know, the challenge, right, is now to get more and more of my colleagues thinking about that. You know, when I'm talking to my cardiology colleagues and my other heart surgeons, and, you know, I don't tend to lead the conversation with, you know, you're wrong about cholesterol, right? I just start to ask, you know, well, what else should we be thinking about? You know, why aren't we seeing these reductions? Like, why do you have so many patients who you have on these medications for years and years and years, and they still end up with the problem, right? They still end up needing stents, bypass surgery. Why is it that patients who have a stent or have bypass surgery, okay, who are now right in the crosshairs of the medical system, okay, we're doing what we call secondary prevention, right? So these patients get treated the most aggressively. Why do the majority of them still die of heart disease? That should be a central question that we should be asking. And in a lot of ways, I feel sad about the medical system in that we don't really think big enough, right? We don't think about curing heart disease. We think about managing it. We don't think about curing diabetes. We think about managing it. And it's really kind of unfortunate, I think, these days that we don't, you know, there aren't more cardiologists and heart surgeons saying, I should be out of a job, right? They should have been right 20 years ago.
Right.
There shouldn't be this much work for us to do. And the reality is that most cardiologists, most cardiac surgeons are too busy to even think about that because they're just overwhelmed with people that are sick with heart disease.
I think that if I'm to represent the devil's advocate in the room with regard to the existing all-cause mortality benefit of cholesterol lowering, many would say, well, the trials are not powered to capture all-cause mortality benefit because they're only powered enough to capture a benefit in, say, cardiovascular disease mortality. Now, I have my own response to that, which is that, well, first of all, we can't then say that we know there's a benefit in cardiovascular disease mortality without having the rest of the balance sheet. Because dying less of one thing doesn't mean you're not dying more of something else. You need to be able to know that. The other, I guess I can say, gripe that I have is if you're wanting to make a mortality benefit, period, I think you need to be able to state that with all-cause mortality. Because again, if you don't have all of the data in hand, that's a problem. Moreover, I don't love it when there's an existing trial that does show or asserts that there's a cardiovascular disease mortality, and yet the all-cause mortality, even if not statistically significant yet, is showing the intervention group at higher levels, as though it's trending in that direction. I give it to people to say, well, currently it's not statistically significant. But the skeptic in me is like, why not at least give it enough time to find out if that trend would continue? Why are these trials set up in such a way that they can be ended early with the emphasis that, wait, we hit this statistically significant threshold on particular endpoints that we were interested in, and therefore now it's unethical to continue it any further? To me, I get worried that that's a bit too artificial, that it in fact should be time-based. And if anything, you can extend on the time. But making it event-based, I'm worried it's a bit too problematic for clouding the data.
Yeah, no, I agree with that completely. And I even zoom out more than that, right? Because I don't take care of trial participants. I take care of patients, right? And I look at, if you just look at the population data, right? Population level data, we should be seeing the impact, right? We've had, statins, the first statin came in the market, right? 1983, 1984, right? They've been the most widely prescribed class of medications now for 30 plus years, right? Where's the impact? Again, since I got told, right, don't go into heart surgery, in the year 2000 to today, heart disease has gotten worse by any metric you want to look at. We did have some improvements, right, initially in the 1980s, 1990s, probably mostly attributable to the change in smoking rates. But, where is the impact from this treatment of lowering cholesterol? That's what I look at a high level. You're exactly right about the trials, right? The trials are stacked to show what the companies behind the trials and the investigators behind the trials want to show. I share the same concerns, right? When you look at the FOURIER trial, for instance, right, the blockbuster trial that led to the approval of PCSK9 inhibitors, and you see that the trial was stopped early after 3.5 years, supposed to be a 5-year trial, supposedly because of a benefit in cardiovascular deaths. And you see that the total mortality in the treatment group is numerically higher, not statistically significantly higher, but right, numerically higher than the placebo group. You should be scratching your head and saying, there might be something to this, right? And you say, okay, well, this is how trials work. But why weren't those patients followed out to 5 years? Like, that could have been done. It's been, I believe, 4 years since that data was released, and we haven't had any follow-up. Some reason I don't think anyone's interested in knowing what the follow-up data shows. But yeah, I mean, and even more so, right? When I say that, that directed statement to my cardiologist, okay, PCSK9 inhibitors were initially approved because of the FOURIER trial. Do you know that there were more deaths in the treatment group than the placebo group? I don't think I've met a cardiologist outside of the low-carb space that is aware of that data.
And this is also why I have a tough time with just clinical trial data in the first place. I do appreciate that there's the larger dream of randomized control, right? Where you actually can have, because the concept of randomized control trials are so powerful in that what you're trying to do is you're trying to make the confounders you are not aware of mean less. So once you can randomize, but as I've talked about many times in this podcast before, I don't love run-in periods. Run-in periods have a lot of problems, particularly in that they may diminish the perceived level of side effects that could be, but it also may just actually impact the trial itself. I don't love this event-based cutting things off, and I don't love how all-cause mortality is not a commonplace. Again, if you're not making the claim of a benefit in mortality, then I don't mind. But if you are going to make that claim, then I feel like you should have it powered for that as well. But there is this other factor, which is just that these are all based on business models. So naturally, what comes to market is a survival of the fittest factor. And here's the challenge that I'm pretty sure you can relate to. I genuinely try to, quote unquote, stay in my lane. I don't want to make any statements that could be taken as advocating for or against any kind of treatment, right? And on top of that, I'll further qualify that even beyond the things that I've just said now, I don't really do a lot of research into these drug trials because the data is just not as compelling to me, not just for those reasons, but also because drugs do a lot of different things. You can say, hey, this drug lowers X, but really it also affects Y and Z and A and B and C and all kinds of other things. If the drugs that lowered LDL cholesterol had a likewise effect across the board, I know it's presented to us that way a lot, but I have pushback on that. If they were very consistent across all the drug trials, across all of the data, distinctly, then I would feel differently about that. I would say, okay, then the other things that they do are less relevant. But a great example are statins. So statins are considered, quote unquote, the gold standard. And many would argue it's because of the degree with which they lower LDL as to what their efficacy is. But I've also met and have talked to many scientists, not just cardiologists, who will say, well, actually, we're wondering how much of it are things like the anti-inflammatory components. And in a person for which there is a very high degree of systemic inflammation, it may be that it has unique efficacy, and that's very common for secondary prevention. Again, the engineer in me thinks, fortunately, you're setting up a scenario of need of possibly a manufactured deficiency, and then meeting that deficiency for this very distinct subset of the population, and then assuming it applies to the rest of the population. That's my concern. And that's why we needed to study people who are metabolically healthy with high LDL to find out if there is this association between the LDL and the development of plaque.
Yeah, I mean, again, that's really the big challenge here, right? Because if we accept cholesterol lowering for what it is supposed to be, right, within the cardiovascular space, that is another big open question. Does this apply to everyone equally? And the obvious answer is no, of course it doesn't, right? Even when you look within the data of any one trial, right, there's variance. There's, the bell curves, the responses, right, that vary so much. And yet we just want to say this applies to everyone, universally. And, cholesterol lowering, I really do struggle to think of another example within medicine where we have, universalized, right, a recommendation so broadly. It really is one of the few areas where we say, yeah, everyone needs this.
And it's just not
the
evidence-backed.
Yeah, the data just isn't there. Again, zooming out and looking at the big picture, right? It obviously does not. On the one hand, right, you have to say, well, it must not work as well for everyone as it does for certain people, because we see failure after failure after failure, right? I have, at this point, it is probably more unusual for a patient that ends up on my operating table not to have been on a statin for a long period of time. So obviously all those patients failed treatment, right? We can argue why, but they have failed treatment. And then you have the other side, right? The question, obviously, that you're focused on, in that, we have this growing group of people who the marker that we're concerned about is outside of the desired range, we'll say, and yet they don't seem to be getting the disease in droves like we would expect. And, now we want to get some more data on that. And, maybe under the hood, the disease is worsening and they will down the line, but maybe not. And if they're not, maybe that's pretty interesting, right? Even if it's a subset of them, right, that aren't getting the disease as we expect. Okay, well, why? Right?
Right.
Let's dig into this. And, there are so many, you're right, there are so many problems with the trials, right? Whether we're talking about the surrogate endpoints and we're talking about the, the confounders, right? And the adjustments. And, again, I always say, listen, I'm just a simple heart surgeon, right? I'm really not a statistical expert, but I can look at a paper, and the longer the section is about, how they needed to adjust and what kind of, manipulation they need to do with the data, that's an automatic red flag. When I was in medical school, I worked in one of the surgical labs, right? And we were doing basic science research. And I had this English postdoc who had the best saying that stays with me to these days, to this day. And he said statistics should be used like the drunk man uses a light post, for support, not enlightenment.
That's great.
And, that's been a big influence, right? Because I read these papers and I'm like, well, if you need to do all of this manipulation, right? If the raw data doesn't really show you what you're looking for, you're probably not looking at a significant effect.
Yeah, I'm going to bring it back to smoking. Do we need a lot of calculations, modeling, et cetera, for there to be those associations that seemed so compelling to so many people for smoking being likely causal? And this is with that full acknowledgement that we haven't done a big RCT with smoking versus non-smoking. It'd be considered unethical right now. And so a number of people are comfortable enough going by Bradford Hill criteria. He's one of the ways by which you can do further evaluation outside of an RCT to say, hey, I can't say with complete certainty that smoking causes, say, lung cancer. But wow, the Bradford Hill criteria, strength, consistency, temporality, all of that, the threshold is extremely high, right? And with the threshold being that high, I can feel comfortable enough making that claim of causality. If you look at these drug trials that provide that observational data, how much are the people putting this together assembling a methodology section that's like 18 paragraphs? They had to adjust for this confounder and adjust for that confounder, and so here's their fifth level model. And only after that point could they feel confident that they could show those numbers, assuming all of the other adjustments are appropriate. Well, this is why, I keep pointing this out to my friends who love observational data. Listen, every single time you run something like a sensitivity analysis where you're saying, hey, I know how much this thing and that thing and this other thing are confounders against the one thing I'm the most interested in. You're actually making a causal claim for each of those. You are saying, I know how much there's a cause by thing A. I know how much there's a cause by thing B in order for me to know what's left over, the remainder, for thing C, right? Again, you don't need to be advanced in statistics to recognize that all adjustments are based on assumptions. They have to be. Better, in my opinion, when possible, to stratify over modify. Go get the group of interest and study them in particular. Why would we say, hey, I think high LDL cholesterol is bad for those people who seem to have some adaptive state, such as being on a low-carb diet, where cholesterol might be higher for a physiological reason? Now, I'll fully concede that that's a hypothesis on my part. That's what we're published on and so forth. But there already should be a bunch of people in the field, your colleagues, who should be saying, hey, this is actually pretty great. We have a population that has high LDL absent those other confounders that are normally needing to get adjusted for, right?
Yep.
This is a huge scientific opportunity. Let's study those people who have the high LDL absent that. And lo and behold, no, not as of yet. I've yet to know of any. It may be happening and I'm just not aware of it yet, but as far as I know, we're the only team that has been prospectively studying people with low ASCVD risks, but otherwise extremely high levels of LDL cholesterol.
Yeah, and we have other data that should lead us there, right? So I'm aware of both statin trials and PCSK9 trials, right, that have looked at the cohorts based on insulin resistance, right, their metabolic health. And again, pretty consistent, right? The patients that are in good metabolic health have low insulin resistance. They don't benefit from taking these medications. And, that should be another sort of thing that gets us to a similar question, right? Because I would broaden it out. I would say, okay, we don't even have to focus on the low carb people. Let's just look at the people that are insulin sensitive.
Right.
And what do we see in those patients? And again, those studies don't get done. And of course, we understand why, right? Again, going back to the business model, right? You don't want to demonstrate who doesn't benefit from taking your medication.
Right.
So I understand it, from, I guess, the, pharma standpoint. But as a practitioner, right, that is exactly my job. This patient that's in front of me, what is the best management for them? What should I be worried about, and maybe what doesn't apply to them? And of course, now as a practitioner kind of focused in with this space, right, the low carb metabolic health space, this is sort of the central question that I have to ask for the majority of patients that now show up to me. And not having, I'll step back and say, and I know you won't say this, right, but I'll say it. I think I have enough data, right, to be pretty confident in telling that patient today that no, you're not going to benefit from cholesterol lowering. And yes, we do need to monitor your disease. And if we see that your disease is worsening, we need to figure out why. But again, I'm fairly confident at this point saying it's not because of your cholesterol level. May have to do with your cholesterol quality, may have to do with other things going on, inflammation, insulin resistance, other things that are going on. But the data, in my mind, as a practitioner, is actually good enough for me to say it is valid for you as a patient if you choose not to go down the cholesterol lowering route. I don't think you're putting your life at risk. I think we need to watch it carefully. I think we need to be looking at a lot of other things, but cholesterol is not the answer to this problem in and of itself. And we'll work on all the other stuff. We'll look at all the other stuff.
So I have our one paying the bills moment. Where this podcast is sponsored by us, by Own Your Lab. So continue getting your private blood testing through us, and then we can keep this, very commercial free. But this is from our desk. We have our team, and they occasionally feed me some questions for whoever the known guest is that's coming up. So this one's for you. The name of your book is Stay Off My Operating Table. Oh, we haven't gotten into your book yet, too, which isn't something you usually hear from a cardiac surgeon. What led you to becoming an author?
Well, what led me to becoming an author was the desire to be able to scale this, right? To get this message out to more people. And I realized that a book is one of the ways that could happen. It wasn't really something I was thinking about, to be honest. I guess the real answer as to what led me to being an author is I became connected with a ghostwriter, and he said, "Did you ever think about writing a book?" And I said, "No, I really haven't." And he said, I said, "Well, what would I write a book about?" And he said, "Well, everything you do, what you tell patients, how you think about this." And I said, "Well, this isn't going to be a very long book. It's going to be like 3 words. Eat real food." Like, that's the book. And he said, no, we got something here. So we started working together, and we wrote the first book, Stay Off My Operating Table. Currently working on a second book, Stay Off My Kitchen Table. And it turns out that, books are good ways to get this message out at scale. And the book is really, Stay Off My Operating Table is really the guide, what I do with patients, what the program looks like. Stay Off My Kitchen Table, the new book, is going to go a little bit more into why we do that, why we think that's the right approach. It's just, I realize, right, that as a practitioner, it's limited how many people I can work with ultimately. And a book is a powerful way that more people can get this information. And, the book's been out 4+ years now, and it continues to be unbelievably rewarding. Each time I get an email that says, "I read the book, I made the changes, all this great stuff has happened," right? And I didn't need to talk to that person. I didn't need to see him for an appointment. They can do it on their own. And that's another kind of focus of my messaging, right? The healthcare system as it is very disempowering to patients. You need a medication, you need a surgery, you need us to do it for you. And one of the other things that I think is so amazing about the low carb community, the metabolic health community, whatever you want to call it, is it's giving the power back to the patient. You don't actually need the doctor to do this for you. You can do it. You can change your health. You can be, in charge of your health, and you can get the outcomes that you're looking for. And in the end, you might need less input from doctors, right? You might need not to be on my operating table. You don't need me to fix it for you. And of course, I guess, again, from a healthcare business standpoint, that's not a great message. But for really helping people change their lives, that's the message that we need to be getting out there.
I think it's a great title. I think that to your point, I think it's a very serious problem with the medical community in general. And a lot of what I hear in a response with even opening the topic of lifestyle, diet change, etc., is it's just not what patients want. Almost as if, and I'm trying to find a kinder word to use, but it's almost as if there's a prejudicial impression of what they anticipate patients are going to be like. And make no mistake, there are absolutely people in my life, in my orbit, who that is how they function. They only go to the doctor to find out what the doctor can give, and ideally whatever the doctor gives, it's going to allow them to continue the lifestyle that they consider to be the one that they can't change. And part of what I wish for those very same people is that they had doctors, like David Unwin and others, who I think have a little bit more of a considered discussion with them, that no, actually with some degree of, putting forth new habits, being aware of what foods you're eating that may not be as good for you. It's not as, you don't have to be in a kind of defeatist state, and that the only place, a lot of the folks I'm thinking of, food is their one quality of life from their perspective. The one thing that is their one and only big joy is that food, which, if it sounds a lot like a drug addiction, frankly, I feel like it's very comparable, right? Yeah. But I have seen in my own family people who did break out of that, who did recognize that, no, just, it doesn't radically change every single thing about their life. They can make some choices that are better. And as they regain more of their health, they actually have more choices available to them for things they can do in life that turn out to really be worth it, and that they can be around for their family and so forth. But it is true. It takes a little more time. It takes a little more concerted effort. It takes more support. I had Chris Cornell on a few days ago. I recorded with him, and he's into health coaching. I think there needs to be a lot more health coaches. There just needs to be a lot more of an apparatus that supports these lifestyle decisions, these changes. But it is true. I do get worried about how much the training for a doctor like yourself kind of sets the stage for this kind of a relationship with your patients. Hey, they just want whatever you can provide uniquely. And that really, a lot of their health is not in their hands. It's not under their control.
Yeah, it's a big problem. And you're right. It starts with the whole sort of education, right? And the I would call it the paternalistic approach, right, of medicine, that the patients are dependent on us, right? That we need to do this. But on the other hand, right, that could be turned exactly to the things that you're talking about, right? Okay, you need the doctor to help you make the diet and lifestyle changes. So how do we do that? And you're right. Let's get the health coaches in there, let's get the right information. One of the sort of, I don't know the right term for it, right? A little bit underhanded, I would say, right? Thing that happened is, we started saying, right, okay, diet and lifestyle matters, right? But then we give patients diet advice that is so lousy, right, that A, it doesn't work, and B, they can't follow it, right? We've demonstrated this over and over and over again, right? Eat less, move more. It doesn't work, and patients can't follow it because starving is miserable ultimately. And if that's basically your only approach, it's not going to work, right? So then we use that in medicine to say, see, diet and lifestyle doesn't work. Right?
Right.
It's like, no, that diet and lifestyle doesn't work. When you give people better advice and you can explain to them, right, that eating, metabolically healthy, it actually isn't miserable, right? I enjoy everything I eat, right? I enjoy what I eat today more than what, the enjoyment of my food that I got back when I was eating, kind of a standard diet, right? When I was eating back then, it was, like you said, maybe there's a little bit addictive, but it was just eating to eat. And, I can't really say, oh, I really enjoyed this. Now, when I'm more selective about what I eat, right, I'm choosing everything that I eat. And I choose it because A, I love eating it, and B, it does get me feeling better, right? So I can have all those other side benefits. And I really, and granted, I admit, right, I have a bias population that comes to me because of the way my practice is set up and because of, who I am and the audience that I have in all of this. But I don't really get patients, saying that they were miserable, right, when they're eating low carb, carnivore, whatever flavor it might be of it. Right? Yes, some of them fall off the wagon for other reasons, but no one really says to me, you know what, I don't enjoy eating this, and therefore I'm not going to continue doing it, which is very interesting, right? Because when I was giving the traditional medical advice and telling them to eat a low-fat diet, right, or telling them to, just restrict calories, you would, they'd come back to you and you're like, why aren't you doing it? And they're like, because I was miserable. I didn't have anything I enjoyed eating, and I didn't, and I was hungry all the time. And, again, my personal experience in this and my experience now with, the hundreds or thousands of patients, right, that we've been doing it with, they actually enjoy what they eat. Yes, you have to get them over sometimes that addictive stuff to start with, right, with the sugar and with the processed food. But once you get them through that, and again, this is all about the empowerment. It's all about you can do this.
Right.
You can you really don't need me, right? Sometimes I feel a little bad, like, you're paying me this money and I'm not actually doing anything for you. You're doing it, right? And we get to a point where, well, you don't really need to keep seeing me. And they're like, well, but I want to. I'm like, okay, well, then keep seeing me. But again, even in my current, telemedicine practice where I'm trying to keep people off the operating table, my goal is to be able to say to them, like, you've graduated. You don't need me anymore. Just keep doing what you're doing. And it's such a different model for healthcare. And that's really a broader discussion about how I think the healthcare system has completely failed and how we can change it, right? It doesn't need to be about low carb. It's just a better way of taking care of people, empowering them they take care of their health.
Yeah, I think you really hit the nail on the head. I'm wishing that there just was overall more of an awareness for people who are stumbling initially to recognize this difference between, this might be a bit of a pejorative, but I had an engineering friend who put it this way: propping up medicine, which is kind of like you're doing enough to get them back out on the street to then go about their life, but with the understanding that they're circling back not long after they were put back out again, because of the fact that they're not given even the skills to consider what it is that they could do next. I want to tell you a little bit of an anecdote. I want to be mindful of the personal information involved, so I can't give the full story, but I can say that there was somebody I know who went to get bypass, and they were diabetic and they were being very good about their low carb diet, and they had an easier time ordering low carb before the surgery than after the surgery. After the surgery, they were put on, quote, a heart-healthy diet. That was actually a standing order. There was some labeling in the system, in the EMRs or whatever, for which, when they were trying to order from the kitchen, quite literally the response was, that doesn't have enough carbs. There needs to be enough carbs for this heart-healthy diet. And I am floored that that's a real thing in 2024, 25, whenever. But I guess there actually isn't, for a diabetic, for somebody who's actually like diagnosed diabetic, who has had huge strides being low carb, that there actually was an awareness of the carbohydrate content of what they were being served. The foods that they were being served.
I see it every day.
So tell me, how are we with diabetes in particular, Philip? How are we here in 2026? How is this really a thing?
But it continues to floor me, and the simple reality is that the system is so far behind, right? The stuff that we talk about, right? The stuff that's out there about, again, this isn't like niche any longer, right? Verta Health has, published this at scale, that we can reverse type 2 diabetes. And yet, if you took 100 random doctors out of the hospital today and you asked them, can you reverse type 2 diabetes? I would be shocked if 10 of them said yes.
Really?
They really have zero awareness. The situation after heart surgery is even worse than you realize based on that anecdote. Because we demonstrated, this is actually so heart surgery is probably the leading area of medicine that focused on outcomes, right? And we have a national database that essentially every patient that has heart surgery gets entered into the database, right? And that over the years, this has been around now about 15 years or so, the database continually gets farmed for, how do we make the outcomes of surgery better, right? How do we make surgery safer, less people die? And there has been a demonstrable reduction in the mortality rate from heart surgery over the past 20 years because of this. So it's at the forefront of what we like to call quality-based medicine, right? And one of the earliest things that was demonstrated out of that database was the better that you control a patient's blood sugar in the 48 to 72 hours after surgery, the better the outcomes are. So we are very aggressive about managing patients' blood sugar around the time of surgery. And this means that a lot of patients after heart surgery, they are getting continuous infusions of insulin to keep their blood sugar under control. Okay, and this is standard of care now in the hospital when you get heart surgery done. And I will routinely walk in the morning after surgery, and the patient literally has insulin going through their IV to control their blood sugar, and there is a glass of orange juice and a plate of pancakes in front of them that are low fat, heart healthy, carb controlled, right? Because the concept is, well, if we're giving them insulin, we don't want their blood sugar getting too low, so we have to give them a certain amount of carbohydrate to balance that insulin. And, again, like when I, walk into a room and it's a new nurse, right, who hasn't worked with me before, or it's a new hospital because I do like travel work, right? And I say, well, how about we take away the pancakes and lower the insulin, right? They'll be like, literally, it never occurs to them, right? It doesn't occur to the dietitians or, the nurses, right? Whoever's managing all of this, that, well, if we put less carbohydrates in, we would need less insulin to keep their blood sugar under control. This is still a foreign concept within the medical system, but despite all of the evidence, right, that we see. We have to acknowledge that low carb, right, is still a very micro niche, within the healthcare system.
This is so disappointing to hear. I'm sorry. This is because we do have data, decades old data. Going to type 1 diabetics, we find industrial strength levels of exogenous insulin, no problem, giving it to them in massive doses. And sure enough, what happens? We have this high association with the exogenous use of high levels of insulin and cardiovascular disease, right? Exogenous insulin, cardiovascular disease.
Yep.
Now, we're talking decades and decades ago. For the documentary, I got to interview Dr. Bernstein, the OG, the GOAT, right? Engineer, becomes a doctor, and unfortunately, he did die last year, but he died at age 90 for not just a type 1 diabetic, but he was patient zero for continuous glucose monitoring because he actually adapted the device so that he could monitor it himself. And he's the original, who is saying, let's go by the law of small numbers. Since I'm type 1 diabetic, why not just go ahead and have less glucose coming in? Then I need less insulin. I can definitely see with my fellow type 1 diabetics that they're dying at very high rates for high levels of insulin that are coming in. So, yeah, I can completely understand why this, per what you just said, I can completely understand why it is that there is this impression that controlling glucose, quote unquote, controlling glucose with keeping it high enough that then the insulin can counterbalance it would probably have greater efficacy for those people, or I should say, would have a better association for those people for which you're successful in bringing the glucose levels down. Relatively speaking, emphasis relatively. Man, I just love to be a multi-billionaire, and I would absolutely want to prop up an RCT on low carbers. Just like get people on a low carb diet against those people who are on this train, this high glucose from the food infused with insulin levels to control it. I really want that. Like, I want that now.
Yeah, no, when you find the funding, honestly, like, heart surgery, right, again, would be the like goal, you could, because we have, again, all the data, right, about controlling the glucose, right? So if we took this to the next level and said, if we can control the blood glucose levels with less insulin, right, do we see those same benefits, like you said, that we know in the type 1 diabetics, right? The less insulin they use over their lifetime, all of these complications are lessened, right? The heart disease, the blindness, the vascular disease that leads to amputation. This, again, is a very personal thing for me, right? My older brother is a type 1 diabetic. And, for 40 plus years of his life, right, it was all about balancing his carbohydrate intake with his insulin, right? I remember early on, when he was diagnosed, right, and I was probably 8, 9 years old and he was like 12, and, the calculations, right, of how much insulin to give based on how much glucose he just had, or, how much carbohydrate he just had. And then, things evolved, right? And he got his insulin pump, and now he could do this a little better, right? And all this time, right, the goal was, well, balance your carbohydrates with your insulin. We're trying to keep your A1C under 7. Then, of course, I stumble into low carb, right? I hear about Dr. Bernstein, who I had never heard about, right? Again, being in the medical system, I think if you took 100 endocrinologists and asked them, have they ever heard of Dr. Bernstein, you'd probably get 95 no's. This is another problem. So he led that life. Thankfully, now he has, learned from me, and now much better controls his glucose with a lot less insulin and is on a much better path. And why this isn't the standard of care for type 1 diabetics, no idea. And like I said, it's not. I don't know of a doctor who is aware of Dr. Bernstein, right, and wouldn't implement that with his patients. But the sad reality is that the vast majority of endocrinologists managing diabetes have probably never heard of Dr. Bernstein. They probably haven't seen the VERTA data, showing you can do this at scale with type 2 diabetes. And again, it's the challenge that we're all working on, right? Getting more and more people to hear about this. And then it becomes, do you want to do this top down and try and get this word to all the doctors? Or do you want to do it bottom up and try and get the word to as many patients as possible, who can then go to their doctors and say, well, why didn't you tell me this? Why don't you know this? And I think ultimately you need some of both, but it is a challenge.
I don't know why I don't just get used to this.
It's
I don't. I mean, I think part of it is that I'm a technologist and we're in the information age. It's available. You can go to my computer. You can go on your phone. You can look this up. You can look this up right now. But I'm also acutely aware that cholesterol has become, I lament this, cholesterol has become such a powerful red herring, I think, because it ends up becoming this rather simple answer to this broader question of relevance. It's like, okay, well, if we know that cholesterol is the central driver, that's the Cliff's Notes over here for cardiovascular disease. These other things, like I went to an NLA conference, and what they like to do at these conferences, and I'm sure you're already familiar with this, they like to break out case studies, and with a bunch of doctors in the room, they can do Q&A and ask, okay, so what did you do? Here's the case, here's the blood work that was run, and it's like a puzzle. And how can we solve this puzzle? And without exception, every single time, wide spectrum blood testing, everything, they never test fasting insulin. You never know if there's hyperinsulinemia. Now you can get a sense when you look at the lipid panel because often they have the low HDL, high triglycerides, which would be a poor man's version of metabolic health. But insulin levels alongside glucose can tell you enormous amounts of information. And we have Joseph Kraft to thank for that.
Yep.
Both Bernstein and Kraft, by the way, should have Nobel Prizes. I don't care if they're awarded posthumously. It's just they should have it. In both these cases, they helped to further illuminate just how much diabetes and heart disease come back to this dysregulation within the body related to these conditions, and how much insulin exposure is relevant towards these cardiovascular disease outcomes. We have enough to not necessarily draw a straight line, but we have enough to compare it to LDL cholesterol. And that's why I say over and over again, you can absolutely believe in the lipid hypothesis, full stop. Just please do me a favor and make a comparison in those hazard ratios against what we already see with things like hyperinsulinemia,
Yep.
with things like metabolic syndrome, and so forth. Don't let this topic suck up all the oxygen in the room to the extent to where you can't, have any additional thought paid to these other specters that are so much larger. I'll just wrap it up with this one point. It's fascinating when we look back in time to things like Eisenhower's heart attack, and it's a huge mystery. What could it be? And that started the whole saturated fat debate. But of course, looking back, the 3 packs a day might be kind of relevant. It's possible. It's possible the food he was eating could be pretty relevant. But the 3 packs a day, I think a lot of us would believe played a huge part. But there was such an impressive blind spot to that because of how much of a desire there was by the general populace to feel that smoking wasn't that bad for them. I think that even though the tide is shifting somewhat, today's population does not want to think the food environment is as bad as it is for their health.
Yeah, I mean, we're definitely, I think, maybe coming to a little bit of a reckoning. But, the other choice that was made back then, right, was, okay, we're going to not talk about the smoking part. We're going to talk about the food, right? But you had 2 prominent camps that were looking at the food back then, right? You had Ansel Keys, right, in the cholesterol focus, saturated fat focus. And you had Dr. Yudkin, right, who was talking about sugar, right? And there was a very intentional choice made back then that we're going to go down this cholesterol route. And you know what? Okay, we had 2 competing hypotheses. We have to choose one. Okay, so we're going to go down this route. But, now here we are, right, all these years later. And I would say that the cholesterol hypothesis around heart disease, right, is incomplete at best, right, being generous. And no one even remembers that Dr. Yudkin did all this work, right? And then Dr. Kraft came behind him and did all his work with insulin resistance. Because you're right, the magnitude is like overwhelming. The most ardent cholesterol, believers, right, in medicine, you ask them, right, so how many patients that, end up on my operating table or, have a stent placed, right? How many of them have whatever we're defining as high cholesterol these days, right? And usually the numbers are somewhere 50, 60%. Dr. Kraft shows that 90+% of patients that showed up with a heart attack had insulin resistance if you test for it properly.
I think he even made a famous statement like
he said, he basically said the patient with heart disease without insulin resistance, you just haven't looked for it hard enough.
Right. It
was basically what
just
he was
has undiagnosed hyperinsulinemia or something like that. Which, to be fair, it was kind of a categorical statement, which we would probably disagree with. But the 90%, that might actually hold up.
Yeah. I mean, because, he did a all-comers study into his hospital system, everyone that rolled in the door with with a heart attack, right? He tested them by his method for insulin resistance, and 90+%, right? So again, magnitude of effects, right? This is a thought experiment, right? I'd love to go, whatever, the American Heart Association meeting, or, you get a large group of cardiologists, together. And you said, would you rather have a patient, right, with an LDL of 40 and an A1C of 7, okay, versus a patient with an A1C of 5.4, and we won't even really go super high, right? Let's say an LDL of 130.
Yeah.
Okay. I can almost guarantee you that probably 95+%, right, are going to take the low LDL with the obvious diabetes versus, a well-controlled A1C with a little bit high LDL.
I think you're exactly right.
Yeah. And, again, we have forgotten that the other hypothesis even existed.
And I think part of why I feel so confident that you're right is because I have family members and friends who have been given comfort by their doctors for when they've gotten their LDL low. There's two friends in particular that I think of who, effectively have the impression they're heart attack proof. But one of them has several markers for metabolic syndrome, and one of them has all 5.
Yeah.
But they have their LDL levels down in the bottom level. I want to say under 60 or under 50, something like that. And so from their perspective, they're like, oh, well, it won't be heart disease. I do have to worry about other diabetic complications. Newsflash. If you're worried about any diabetic complications,
let's fix the diabetes.
You're at a heart attack risk.
Yeah.
Unquestionably, given the present data. I don't know how you can come to any other conclusion.
Yeah, no, exactly right. And again, I see it all the time, right? Because, sort of the reverse, right? Because we have the patients who fix their diabetes, they go on a low-carb diet, and forget about the lean mass hyper-responders, right? Because we know that the average data shows us that cholesterol doesn't change, right? Population-wide, Dr. Unwin's data basically showed that the LDL didn't change in his low-carb population, and yet those patients will still, and again, I see this all the time, right? They go to their doctor, and, they've dropped their A1C from 7.5 to 5.5, and, their LDL, right, ends up in the 120, 130 range, and they get told, first of all, it gets blamed on the diet, even though the cholesterol may have been the same before they started the diet, but most doctors don't even look at that. But they still get told, that this diet is killing you because your LDL is too high. And it just...
It's actually, and we're published on this for what it's worth. We have a meta-analysis of 41 randomized control trials that had at least one arm that was low carb, and low carb enough to where it might have affected LDL levels. Go to cholesterolcode.com/papers if you want to find the one I'm talking about. To your point, yes, David Unwin's population is going to be typically higher BMI. If you are higher BMI, this is per our own study. If you are a BMI of, let's say, 25 to 35, and you go on a low-carb diet, it is unlikely your LDL will change too much.
Yep.
To your point, it wouldn't be surprising at all to have an LDL go from, say, 120 to 130. That's a negligible change, right? This, by the way, happened with my dad and my sister. Their LDL levels went up just like a tiny bit, whereas mine doubled. That's what happens for people like myself who tend to be BMI of, like, say, 25 or lower. And our meta-analysis supports this. In fact, the lower the BMI, the higher the change of increase in LDL levels. Now, interestingly, though, if you have a BMI of 35 or higher, so very definitely well into the side of obesity, and you're moving down into more overweight but not quite lean, typically LDL levels go down, if anything. But to your point, what is very common is when somebody is making a lifestyle change and what they're telling their doctor is, yeah, actually it turned out I just need to cut out the carbs. Now I just have, instead of, a cheeseburger, I have 3 patties with bacon and cheese on it, and just I skipped the bun. And it worked. I've lost all this weight. You notice my blood pressure's down, and my now I'm able to do some running. Before I couldn't run anymore. And I think it's a bit of motivated reasoning. I think that a doctor is going, okay, but that does sound a little concerning. It's a lot of red meat. It's a lot of saturated fat. Let me look at your LDL levels are above 100, right? I'm worried that this diet is contributing to LDL cholesterol and it's going to give you a heart attack sooner. I have never in my life had so many people express opinions of concern for the diet that I'm on, not just my doctor, but hanging out with friends when I'm doing something like having, say, 3 burger patties with cheese and bacon or something like that, who did not bat an eye when I would have loaded fries or hot fudge sundaes, or we would have a giant pizza, right? Or just pie or something, things things that I think are more objectively concerning. Although, I don't know. I guess there are many people who might be watching this now who go, no. The 3 patties are much more concerning than the hot fudge sundae. I never know anymore. It's just funny to me how much you get the side eye on low carb choices.
Yeah, it is amazing. I'm optimistic. This is starting to change a little bit. Again, I don't think it's really the majority, but, I think there is more awareness of this now. The recent changes, the new food pyramid, it's going to help. Although in a weird way, because of the politics affiliated with it, it's sometimes, you almost have people now arguing for processed food, which is just simply amazing to me. It's like, I
It's
guess
violating your 3 words.
Yeah, we can argue about how much impact, more processed food might have on our health. But I can't imagine anyone arguing, but it does happen, right, that these things are beneficial to us in some way. And that's kind of the weird place we find ourselves in, that people will now defend, right? No, you got to have the processed food, right? It's essential in some way. But, again, I am optimistic that I think the environment is starting to change. I think people are recognizing this.
How do you feel about the new dietary guidelines? Do you feel like that's been a big...
Yeah, I think they're a great start. They're not the whole solution, right? There maybe are some minutia in there that we can start to argue about, but just the fact that we have, a flipped upside down food pyramid. We had a Super Bowl commercial talking about eat real food, right? We have a government website that is realfood.gov, right? These are all things that are at least starting to change the zeitgeist around our food, and I think more and more people are paying attention to it. And ultimately, that is the first step, right? Getting back to kind of what we talked about earlier, right? Getting back to that basic acknowledgement of what you eat is the major determinant of your health.
Yes.
And, again,
I think
that most doctors don't acknowledge that. They're like, what you eat doesn't really matter. It's your genetics and it's your, lack of medication basically that's causing you health problems.
I used to think that myself. I used to think that health was, in a pie chart, that a third of it was exercise, a third of it was diet, a third of it was random chance, genetics, environment, fill in the blank. The me of today, I want to say it's maybe 85% minimum is what I am consuming. It's what you're consuming. And this is not to diminish the importance of exercise, regular exercise to some degree. But how much diet in particular is so impactful to health, I think is just so unquestionable now. So bringing it back to the food pyramid again, or the upside down food pyramid, I'm fascinated by how much there's a division within the low carb community, and that a number of people are like, oh, thank goodness, this is such a massive step forward. And then I have some friends who are like, this is closer. There is at least more of an acknowledgement of real food. But for example, the saturated fat limit didn't change. How can there be more of an interest in things like low carb, even if the pyramid seems to reflect a little bit better? If you're not changing something like saturated fat, then what do you do?
Yeah, no, I mean, I acknowledge that point, but I think we have to kind of take the victories, right, as
yeah,
they come,
take
right?
the W.
You know, and we have to acknowledge, right, that undoing 40 years of, beliefs isn't going to happen overnight.
It is the biggest, I think everybody can agree with this. It's the biggest single change.
Oh, yeah.
That I think's happened in my lifetime.
Yeah.
With the dietary guidelines.
And the saturated fat part of it, it's in the footnotes, right? It's in the document that most people don't read, right? And, yes, you and I have a lot of the same friends, and I can imagine who some of those people are that are, hyper-focused on that aspect of it. But the reality is that, the old food guidelines, no one read the 150-page report that came with it. The new food guidelines, I think very few people are reading the 9-page report that came with it. And the saturated fat is a footnote. They're going to look at that pyramid. They're going to say, okay, I should be eating the stuff that's at the top. And the reality is, the average person doesn't think about saturated fat, right?
Right.
They don't read the food labels.
Well, and right there in that upside down pyramid, there's a number of meat products, for example, like just the concept of the dietary guidelines moving towards more of a plant predominant diet is, it's fairly a given. And there was, you've got Eat Lancet that also tries to press that it's also for the benefit of the planet. It's not even just for individual health. And this, to me, it felt like there was a shift. It's a bit challenging because, as you kind of alluded to, there's a political component to this. But do I feel like, by and large, the average person that I know in my life seems to be a little bit more aware of metabolic health and the value of eating real food? I feel like I've seen this more in, like, say, the last year. I never know, though, because I also have a lot of friends that are low carb, so that might be a factor.
No, I do think in the general population there's an awareness, right? I was, one of the things that I think was great about the food pyramid is it did put meat at the top, right? And it started to, again, counteract that push towards plant-based diets. This is something that we talk a lot about in my upcoming book. Eat real food is the base, right? But I do think there is enough evidence that I'm comfortable as a physician saying meat is essential to health. And plant-based diets are an improvement over junk food, right? Over a standard Western diet, we'll call it, the old food pyramid even. You can demonstrate that. I acknowledge it. But the belief that if you're eating real food and you're only eating plants, that's better than eating real food with meat is, I think at this point, demonstrably false. And I do think that meat is essential to our optimal health. You can be healthy if you're only eating plants and if you supplement properly, but I don't think we can say that you can be optimal anymore without eating meat. So I was very enthusiastic to see that they put meat pretty prominently up in the upper corner of that thing. They put whole dairy, whole fat dairy, real dairy, I would call it, up there. And yeah, there were some veggies. And, the way that I explain it to people now, my advice as their physician is you can eat the veggies if you want. For a lot of people, they're not harmful, but they're not essential. And there are some people that do have demonstrable harms from eating, plants. So carnivore is an option. It's not the only option, but it is a valid option. And of course, we know plenty of people that have thrived on this. I really don't know people who thrive on a vegan diet. And the ones that are doing better than they were doing on a standard Western diet, on a junk food diet, they can do that for a while. And the more, the better planning they do, right? And getting the right supplements and balancing their protein sources within the plant kingdom, it's very hard, and you can do it for a while. But I have now seen over and over again that breaks down over the long term. And that's part of the discussion we have in the new book about what the role of meat as an essential part of the human diet is.
I have a complex opinion on this. I'll play kind of devil's advocate in that there's a handful of people I know who are on a plant-only diet, or I guess some of them would even say they'd prefer I just say animal-free diet. It is true that the two people that I have in mind who I've known for a long time, who I know are truly just plant predominant, are both very aware of the supplementation. This is a big deal, I think, that can never be understated. Even for those people that I know that are doing fairly well, they're mindful of things like B12 and vitamin D. You want to be mindful to make sure that you get that. It's things like a B12 deficiency you may not realize for a while, and then it can rear its ugly head, and it's a really big deal. So I think I've seen enough, at least anecdotal data, that there are some people who seem to do well on a plant-based diet. That said, vegans themselves will acknowledge there's a high recidivism rate. And one of the more fascinating things that I watched happen in real time, but I remember having tabs on her in my mind after I saw it, was Super Size Me, Morgan Spurlock, I want to say. His wife was a very famous vegan chef. And I hope I'm reciting this story properly, but she had ultimately determined that she had to leave veganism. And what had happened to her was, even in spite of being very successful in the movie, brought up her profile a lot, she was eating with a friend, and she just was watching the friend eat a steak, and it just became overwhelming to her that she really wanted to eat that steak. And I kept thinking, wow, that's a big deal. If you ever were to have somebody in a position where their profile is built from it, they've got a long span of time of being not just a strong adherent to veganism, but in addition to that, being excellent at cooking, very, good vegan dishes and so forth, to have this unique desire to consume meat. It does, to me, suggest that even for as good as she was in putting things together, that there might actually be some deficiency that was getting met with the steak. I'm always fascinated by the concept of desire towards the complement of amino acids that would be typical in animal food.
Yep.
But yeah, there are a number of people who've been longtime vegans that ultimately fall off. But to be fair, are there, for example, some carnivores who've reintroduced plant-based foods? As of the time of this recording, of course, the more famous case is Paul Saladino. But I'll also point out that Michaela Peterson, I believe, has also started reintroducing some things because she feels like she can tolerate it now.
Yeah. Yeah, no, I mean, there are certainly examples of that. And that's why I say, no, I'm not convinced that carnivore is the answer, right, for everyone.
Right.
But I think it's a very valid option. And I think there are a lot of people who need it, at least for a time period, right? And Michaela is a great example, and I think people with these autoimmune conditions are a great example. And I think it's great, right, that they have gotten to a point, right, her in particular, her story, that she has healed to the point that she can reintroduce these things. Now, again, at least from what I've heard from her, right, she didn't do it because she felt there was some deficiency in her carnivore diet, right? She did it because she had to be so restrictive, and she
Right.
doesn't want to be so restrictive anymore. And great, and I think Paul, and Paul and I have had this discussion, right? It's great that Paul thrives now on the diet that he thrives on. But I also don't think that that's the right answer for everyone, right? I think the people who try and say, "Oh, look at what happened with Paul and carnivore doesn't work," right? I don't
Yeah.
think that's a great argument. I think Paul is a very unique situation, and I see others like that, that are in his situation, right? They're
Well,
very young, they're very active, they're very lean, and they just can't get enough. Now, and again, I've had this discussion with him. I said to Paul, I think you could have made other modifications, right? Maybe you needed to be more high fat within your carnivore framework.
I've
Maybe there
wondered
were
about
other things,
electrolytes.
right, that you could have modified that could have had similar good results that you got from adding back carbs. And again, that's why I'm not here saying carnivore is the only option. I think carnivore is a good option. I think we need to get that message out there more, right? And especially, coming from the heart disease space, this again circles back, right? Because here I am in the heart disease space saying not only is red meat not harmful, but I actually believe it is beneficial and essential. And if you have heart disease, which again, going back to our earlier point of Dr. Kraft's work, that means you have insulin resistance. You probably should be looking at a low carb diet that is very heavy in animal products.
Yeah, I so a few different things to unpack there. Yes, it really can't be understated that we're right now in this moment in time. You're one of many who've sat down, who work with human hearts, who is of the position that, no, not only am I not saying don't limit your, say, red meat intake, but actually you can see people benefiting in their cardiovascular disease health by being on a diet that may be entirely red meat,
Yep.
right? To be fair, and to expand on your point, this is a very, I know the word restrictive might be considered pejorative, but it's a restrictive diet. It's saying, hey, we're limiting things intentionally. And why is that being done? Well, like in the case of Michaela Peterson, that was the one way in which she could feel normal. It's one way in which she could live life. There are a number of people who I remember in forums would almost call it a trap, like the carnivore diet trap, because some of them, once they went on a carnivore diet, they felt so good and recognized that now they, because it's a good multiple removal diet is a term that's used for a diet where it's very narrow, but you've removed so many different types of foods that if there was something you had an allergy to, a sensitivity to, an intolerance to, then you've categorically dropped all of these things off so that you could then find out that, oh, I have some kind of allergy or intolerance. That's the value of a multiple removal diet. What normally is the protocol of a multiple removal diet is to introduce things one at a time, and usually intentionally by a lot,
Mm-hmm.
to see if it perturbs, if it activates that intolerance, right? Carnivore is really, really, really good for this because I don't know that I know anybody who has an intolerance to red meat, like an actual, they have a unique allergy, something like that. So in being on that, they can then find out if there's an effect. And on top of that, you will be low carb, you'll be ketogenic because you have no choice. So you're going to become fat adapted.
Yeah.
Well, okay. Now comes around this other factor, which is that, okay, I may or may not have found out that I have some kind of intolerance, but I really do want to have other kinds of food. I miss salad. I want to have salad. Can I have salad? Probably most diabetics can have salad. It's a low starch, but something different like potatoes, it's different. Some of my family members are diabetic to the point that a potato is going to be a problem for them, even though it's pretty fibrous, right?
Yeah.
I have a family member who's very diabetic, really loves strawberries. And we at least try to work out the timing of when they consume it, which can be helpful. But there's just no getting around it. They are just that insulin resistant. If I could, I'd have that person just on a carnivore diet because of how insulin resistant they are. And so getting back to, this is the major thing I want to come back around to, is Paul Saladino is very physically fit. The carbohydrates he's reintroduced, I'm confident he's burning off like crazy.
Mm-hmm.
He's surfing all the time.
Yep.
He does a whole lot of outdoor activity. And this is where I turn to a lot of my sedentary family and friends, and I'm going, recognize the context. When you look to a fit-fluencer, as they're commonly referred to, and they were low carb at first, and you found when you went low carb, it was helping you out a lot. And then they said, oh, you know what? I've changed my mind now. I find I do well, having fruits and a whole bunch of other things. Just be sure that if you're still following along with them, if you're not at the activity level that they're at, that's another version of lowering carbs.
Yeah, exactly.
You're lowering glucose by burning it straight up. And if you don't have a body that's great at handling glucose because of this diabetic dysregulation internally, it's going to be relevant as to whether you can do what they're doing.
Yeah, very true. And again, this is where, I'll bring in with my patients, right? We have a great tool that you can use to demonstrate this, right? Put on a CGM. And, all those questions you're asking about, can I eat this? How much of it can I eat? Put on the CGM and let's see what the data looks like.
You can't beat it. No,
you can't beat it. And it's an amazing tool. And again, this is another area that I'm optimistic, right? Because now they're over the counter. I hear less of the objections from other doctors about, for some reason, a CGM shouldn't be put on, this population or that population, right?
I get so frustrated about that. I feel like, Philip, there's just sort of a number of people that if the low-carb community is interested in something, it's like they've got to take the other side of it. And a CGM, I believe that pretty soon we will have non-invasive CGMs, such as an Apple Watch, a Samsung Watch. Oh my gosh, I wish it was here tomorrow, because
Yep.
I do have people I care about who I want them to wear a CGM, and they're going, that's not going to happen. Okay, fine. Would you wear a watch? Yes. Come on, technology, bring it to us. I'm confident, and I'm sure you are too, that a sizable number of the population is going to find out that they are diabetic. Didn't know that before. Once it's just a feature on the watch.
Mm-hmm.
That's what they need.
Yeah.
I'm quite positive that will actually be a kind of mini revolution of sorts. And that now people will start really caring about what their individual level reaction is to various foods. Because you basically have an oral glucose tolerance test that's always on. So you'll become more aware of the foods you're eating, and particularly if you're overstuffing yourself, which I just wish more people were aware of in general.
Yeah, I think, again, going back to the discussion around the food pyramid, right? If we were able to get rid of all of that and just say, eat in a way that your blood sugar doesn't go up, that revolutionizes health, right? And going back to the work of Dr. Kraft when it comes to heart disease, right? If we did that, I am quite confident that the impact on heart disease would be just massive, right? Would put all of this cholesterol stuff to shame. If we just told people, eat so that your blood sugar doesn't go up. And again, it's a very simple entry point within my practice these days of, people come to us and they have all their, beliefs about what they can and can't eat or what they should and shouldn't eat. And these days it's just put this on for 2 weeks, watch the curve, and note when it goes up and when it doesn't go up. And the stuff that you eat that it doesn't go up, just start eating more of that, right? And that is a very simple way to get people headed in the right direction. And it doesn't need to be, it doesn't need to be a diet that you're starting, right? A camp that you're in, low carb, carnivore, vegan, whatever it is, right? It just eat so that your blood sugar doesn't go up. We know that blood sugar, is the predominant thing that is damaging the blood vessels that then allows the cholesterol to become problematic, right? When it comes to heart disease. And we know that, the effects that blood sugar is having in the brain now that leads to neurocognitive problems and psychiatric problems. And we know how glucose fuels cancer. And we know all of these diseases that we're worried about, right? They all tie back to the same thing. If your blood sugar isn't going up, you're going to be at a lot lower risk for all of these things, most of these things. There are a few exceptions, but if we could just reframe our whole healthcare system, I would say, around controlling people's glucose levels, the impact would be massive. So I share your dream that we're going to have, soon enough, the glucose monitors that are non-invasive, and they won't be perfect, but they'll be good enough that people will be able to see the impact of what they're eating and everything else that they're doing in their daily lives on their blood sugar levels. And, that's going to get us.
It's going to be the biggest game-changing device in a while. I'll expand on what you were saying just now. It's not so much whether the glucose levels go up; it's whether they're controlled. So so it's true if you're
within
on
range.
Yeah, if you're, I would say this to a family member right now. If you're wearing a CGM, whatever you're eating, if your glucose levels after the meal, 2 to 3 hours later, are back below 100, you're probably fine, right? Like if it started below 100, it ends up being persistently below 100 as opposed to a hypoglycemic effect where you like dip way down and then you're in the roller coaster. You're likely metabolically healthy, because in the case of someone like Paul Saladino, I'll bet that that's what's happening. He eats, bananas along with other things that are in his meal, and because of his metabolic health, his level of activity, etc., his liver glycogen stores are like, gimme. And he gets a whole bunch of those, and he's repleting more glycogen stores in his muscles and so on and so forth. Again, it's fine. If that's the metabolic state you're in. But if you're wearing one of these CGM or someday wearables, and your glucose levels remain persistently high, they go way up and they're staying up there. Okay, well, that's the whole reason we did an OGTT back in the day, was to see, oh no, after so many hours, no, you're actually not seeing a return to normal because you have an inability internally to control your glucose levels, given all else being equal, given the state of things. So let me jump. What I'm normally doing with guests is I'm usually doing a bit more of their biography on the front end. We're switching it up, and I'm going back in time now, a little bit deeper into the podcast. But this was fun, kind of jumping in from this direction. Let's go back to when you determined you wanted to be a heart surgeon. When did that happen?
So I, from a very young age, knew I wanted to be a surgeon.
Wow.
This is very interesting. Yeah, my parents swear that as early as 5 or 6 years old, people would ask me what I wanted to do. And I didn't say I wanted to be a doctor. I wanted to be a surgeon. And I have no idea how that would have happened, right? I have no doctors in my family. I have no surgeons certainly in my family. I didn't have surgery as a kid, something like that, right? But somehow that was my path. That was my destiny.
Not astronaut.
Not
fireman. Not those usuals.
Yeah, exactly.
That children have. You're like, I want to put my hands into people.
Something was driving me to that. Throughout high school, I did things to kind of fuel my interest in medicine, volunteered at hospitals, those types of things. Knew I was going to go to medical school. So I actually went to what's called an accelerated undergrad med school combination, pre-med med program it's called. And then I, got through medical school. And again, knew I was going into surgery. So I started a surgical residency. And back when I did it, it's a little different now, but, pretty much almost all of the areas of surgery, you would do what's called a general surgery residency. It's 5 years usually. And then about year 3, you would start picking what area of surgery you wanted to specialize in. And so, that brings me to the story I told earlier. Heart surgery just fascinated me from both the technical aspects of actually doing the surgery and the physiology of the heart. Putting people on the heart-lung bypass machine. We actually stop their heart, do the surgery, start it back up again, hopefully. Most of the time, yes, successfully. But it's kind of just an amazing, technical feat, and it has all this great physiology. And so it really grabbed my attention from, early on. And despite my mentors trying to dissuade me from it, I decided, I wanted to go into heart surgery. And so after completing my 5 years of general surgery training, went on to do a fellowship 2 years in cardiac surgery, and haven't looked back. Never regretted that decision. I still love doing it to this day.
Let's unpack that a little bit, because I think that a lot of people hear about this from outside. They're not actually realizing exactly what you just said, that there's a real technical component that, for as much as it has advanced, for as seemingly routine as it might seem for how many of these operations take place on a daily basis, it's actually quite a big deal. The heart is not meant to stop.
Nope.
It is meant to just keep rolling all the way to the very last day. And it actually is not Hollywood. They're pulling out the defibrillator, and they're like, shock them, and it sounds like it's just like jump starting a car, right? Like, it just, try it again. We got it going. But in reality, it's very electrical. And in fact, the defibrillator part of what it's trying to do is get this perfect cascade going. It's not a muscle in that it doesn't just like squeeze in one direction. It's actually kind of like a series of straps. Would that be a good way of putting it?
Yep.
That has to conform in a very distinct fashion. And it really, even this is a little bit of an oversimplification, but it could be argued it's kind of doing a two-way process. It's almost like a figure eight. One is heading its way into the body, the other is heading its way up to the lungs for this exchange back and forth between oxygen-rich blood and CO2-rich blood that's meant to go back out for the exhaust. And the issue is that what you're trying to do is hit pause. And this is where the bypass part comes in. You're trying to say, we need to simulate what the heart is doing for the patient. And that was a gigantic feat in medicine for the longest time.
Yep.
I actually don't know this, but I'd be curious. Do you know how old bypass actually is?
Yeah. So, and you as an engineer would find this fascinating. So John Gibbon was the first surgeon that successfully did bypass in a human. John Gibbon, and this maybe was part of the destiny of my story, right? Because he worked at the medical school where I went to medical school, Jefferson Medical School in Philadelphia. So John Gibbon, when he was a trainee doctor, young doctor in the 1930s, had a patient that died of what we call pulmonary embolus, right? So they have a big blood clot, goes to their lungs, and when these get big enough, it basically, the heart can't pump effectively and the patient dies. And he said, if we had a way that could have supported this patient's heart during this, we could get him through it. It was 30 years of work, essentially, for him to develop the heart-lung bypass machine. He worked, he actually had to reach out to engineers at IBM to help him with the design of this system, right? Because you need to pump the blood around. You need to put oxygen in, take carbon dioxide out, because remember, we're not only taking over the function of the heart, we're also taking over the function of the lungs.
Right.
Because of the anatomy, you basically can't bypass one without the other, essentially. So bring the blood out, pull the CO2 out of it, put oxygen into it, pump it back in, do this without having the blood clot, do this without damaging the red blood cells, and the platelets and everything else, all the cells that are in the blood, right? It was a massive technological engineering feat. So 1954 was the first time this was used in a patient.
Wow.
So we've only been doing this for 70 years. Prior to that, the whole history of heart surgery is fascinating. There were some unbelievable things that went on that, just today, like, IRBs and stuff like that, right? Trying to get some of this stuff,
Yeah.
No way that any of this would have happened today
Right.
if we were trying to start heart surgery today. But prior to his work, essentially it was believed that, if you tried to operate on the heart, patient would die, right? There were some things you could do before that, but, basically 1954 was the first time he did it. Another fascinating historical thing. So most of the problems back then were what we call congenital defects, right? People were born with holes in their heart or, things that weren't flowing in the right directions. There are all sorts of things that can happen as the heart is forming that will cause trouble. And so the original cohort of patients were all patients with holes in their heart, essentially. But remember, we didn't have a way of actually looking at the heart from the outside. So the only way they could kind of guess where the hole was listening to the heart and what we call murmurs, which are sort of the abnormal sounds that occur when the blood isn't flowing exactly as it should. They would diagnose based on that and some rudimentary EKG, looking at the electrical patterns, what was wrong with the heart. So the first case they did, successful. Young lady had a hole in the upper chamber of the heart, what we call the atria. And technically, that's easy to fix surgically, we'll say. I mean, back then it wasn't, right? But today, pretty easy to fix. So they do the first case, it works great. They do the second case, and what they thought was a hole in the upper part of the heart was actually a hole in the bottom part of the heart, what we call a ventricular septal defect, which is much more complicated to deal with, even today. And back then, they really couldn't deal with it. Patient dies. Third patient, same thing happens. Patient dies. So 3 cases, 1 survives, 2 dies. John Gibbon says, this is never going to work. We're not doing it anymore, and stops doing it. But
Really?
Thankfully, other doctors, elsewhere in the country had kind of been aware of what he was doing, and they picked up the work, and, it then became, what it is today. But yeah, people don't realize, we've only been doing heart surgery for 70 years. This, I think, is another aspect of it that was so sort of fascinating to me. And, it really...
I guarantee, though, there's going to be a ton of people who are going to say, 70 years, that's like a huge long time. That's a lot. But to your point, in medicine, things go slow.
Yeah.
And I've been in the sausage making. I've got a lot of complaints to make as an engineer about how slow things go. But to be fair, it really was a huge feat. I want to draw attention to 2 more things in what you just now described. A lot of people probably don't realize that the blood, the blood is quite literally is made to be very clottable. Like that's actually by design.
Right.
Half of the cells in the blood are immune cells. And it's for good reason, because when we have an opening, when we have something that's hemorrhaging, the body on its own, without us actually being, we may be unconscious at the point that we're, dealing with some injury or something. It needs to be able to attend to it on its own. So when you're handling this freeway of blood that needs to be on demand at all times to all cells everywhere throughout the body, you have to solve for that. And then you have to solve for the blood pressure. Just not like blood pressure. Probably people are just thinking about it in terms of, well, you just you're hitting a little throttle or something like that. It's like, no, what's normally going is, the term stroke is this specific hemodynamic, pressurized push that just goes in a particular, way. Actually, that's a good question for you that I don't know myself. Are you simulating the strokes of blood moving through circulation, or is this a different style of throughput?
Yeah, so you can do it both ways. With the way that the heart-lung bypass pump works, you can actually do it both ways, but the vast majority of the time we do it with a continuous pump that actually doesn't cause systolic diastolic.
Gotcha.
It's a flat blood pressure. You're maintaining the blood pressure at a certain level, but it's flat. It's non-pulsatile, what we call it. The studies between those two methods, because you can do it, you can have a pump that basically causes a pulsatile output, but it's more complex, and it has never been shown to be better than doing the non-pulsatile method. So the vast majority of bypass is non-pulsatile.
Interesting.
So we're maintaining a constant blood pressure, but it doesn't have systole diastole. And the body tolerates that for shorter periods of time, right? If you start getting into longer, this is one of the problems that comes up. The longer you're on bypass, you might start to see some issues related to that.
So we're well into the weeds here, but I can't help but bring this up. You're probably familiar with VCAM with regard to atherosclerosis.
Mm-hmm.
So where this gets really interesting is the nature of how everyone's always thinking in terms of, blood's just flowing. It's like this river that's coming through. But no, this pulsatile effect that you're talking about, like you're just thinking about it in terms of it's coming through and slowing and then bringing up, that's the diastolic to systolic thresholds. Well, at the sites of endothelial cells themselves, there is some relevance to that slowing down and then speeding up and then slowing down. And this brings it back to the immune cells. Things like receptor binding, potentially that becomes very relevant for the slow down period before the speed up period.
Yeah.
And VCAM is the process by which it's almost kind of like speed bumps to slow down to then capture immune cells that can then be differentiated into, the most prominent example being monocytes into macrophages. But there are other things, neutrophils and so forth, for which these things become relevant. But I can't help but wonder in what you just now described if there's a continuous flow, even if you're hitting a nice happy medium between, if that might have net detrimental effects. Or something like that for the immune response. The catch is it's such a short span of time,
right,
relatively speaking, that it may be not really that relevant.
Yeah, yes, during the short period of time, in a typical operation, we're going to have a patient on the bypass machine, with this continuous flow for a couple hours at the most. The more complex operations that we do, maybe we extend that out to 6 or 8 hours, but we really rarely get beyond that. Now, what's interesting is we do actually have a modern example of this, right? So we now have people with what are called LVADs, left ventricular assist devices, right? So these are patients whose hearts have failed, and generally they're awaiting a heart transplant, and we're basically using, essentially it's just heart bypass, right? So their lungs are still working, but this pump, this device has now taken over the function of their heart in terms of getting the blood to circulate around. And those can be used for longer periods of time. Dick Cheney was a famous example of this. He had a LVAD in for, I think, almost a decade before he died because he wasn't a heart transplant candidate. So he had what was called destination LVAD, meaning that you're going to live on this machine for the rest of your life. But, so that's an example of where it's still that, non-pulsatile flow that gets done long periods of time. But you're right, there are consequences of that. They start to develop kidney failure. They're at higher risks of stroke happening, and there probably are other things, right? But that's the trade-off, because without it, their heart has failed and they're going to die. So it's a very interesting problem. But yeah, from your engineering brain standpoint, the cardiovascular system is, there are endless numbers of rabbit holes you can go down thinking about how that whole thing works.
Well, I mean, there's just no getting around it. It's such again, going to the Hollywoodized version of things, it's, oh, so-and-so needs an operation. The operation was a success. You very rarely see there were post-op complications. What are the nature of those post-op complications? What happens in this case, in that case? One thing that I'm impressed by with with thoracic surgeons in particular, is seemingly all of the ones that I've met, have almost like an eidetic memory for the various statistics of different outcomes for what they're deciding to do. So it's not like, hey, here's this new tool, and here's the study applied to the tool all by itself. They actually tend to be more skeptical within their field and seem to be much more problem solvers. There's almost a little engineering, style to you guys that I like, where you're being very discerning and very skeptical on the approach of new techniques. And because I think a lot of it's just that there's more of a visceral connection. You probably have, when there's bad outcomes, it's like right there in front of you, much more so than a lot of other doctors who are like, well, take this drug for a while, or here's a procedure we could do, and, maybe it'll be relevant or maybe it won't. It really is in your hands a lot more compared to other professions.
Yeah. I think that's part of, what has kind of led me here from the sort of, standpoint, right? Is, you're I guess you could call it the BS meter is a lot more attuned, because the outcomes of what we do as a heart surgeon become very obvious very quickly, right?
Yeah.
Versus, okay, you put a patient on a medication, that's supposed to prevent them from having heart disease, and 10 or 15 years later, they have heart disease, right? And
how much was
that's
it
a failure,
right?
But it's not as, I guess, the direct connection versus, I'm in the operating room, and if something I do goes amiss, or maybe it's something with the patient goes amiss, right? The outcome becomes very apparent very quickly.
And per the other example, you don't know as a doctor how much things outside the cholesterol-lowering medication were relevant towards the outcome. Whereas what you're doing, again, so much can happen literally right inside the operating room. And that feedback loop is very present in your mind, I'm sure. But then the recovery period, just post-op, there already is quite a lot. I think again, people need to not watch Hollywoodized versions of ER and see it up close and personal to get the sense of just how much is involved in recovery from like cabbage.
Yeah.
It's a lot, right? And there's still, frankly, there's just a lot of things that can go wrong. That's not anyone's direct fault necessarily. But there's a reason why there's lots of constant, monitoring, things like chest tubes. There's a lot. There's a lot of big stuff there.
And again, I think understanding the magnitude of that is part of why I'm here, right?
Yeah.
Because I really understand what happens when we fail to prevent heart disease, right? Not blaming anyone or anything in particular for that, but I know the very real consequences when heart disease doesn't get prevented. And I think that's part of what makes it, a greater magnitude thing to me we need to prevent heart disease. We need to do a better job at preventing heart disease or arresting it at its early stages so it doesn't get to this very, massive thing that I then need to do to go in and try and rescue this person. Right? One of the things I've said many times before is no matter how good I might be as a heart surgeon, the patient is never going to be as good after I do the surgery as they would have been if they didn't need the surgery in the first place.
Right.
And, again, I think that's part of why I'm so passionate about this. Part of why I'm here is because I understand the true consequences of failing to do this.
That's very well said. For me, and I was actually talking to Mattis about this before we were recording. For me, the misdirect is part of the engineer in me. It's not even just trying to get a sense of what all is going on and understanding it. I feel like so much of it, as we were talking about earlier, is already there. It's already like the data is available for us to look at, get a hold of. What is strange to me is how people can have such a long-standing misimpression of how we do end up in this place. So going back to Eisenhower and the smoking, I feel like if either one of us was blasted back in time, we'd be like, hey guys, you're not paying enough attention to the smoking.
Yeah.
The smoking, huge deal. And while we can't say with complete certainty that this is exactly why Eisenhower had the heart attack, we can't say it with enormous confidence, right? So by the same token, if, heaven forbid, if one of my friends that I'm describing, who's a challenge case, has a heart attack in spite of how confident they feel right now and how low they've gotten their LDL cholesterol, I don't want to be the friend that goes, I told you so. I want to be the caring individual that's in their life that got them to just get the data that I'm bringing to their attention, right? But yeah, after I've had times where I've witnessed firsthand visiting people in the hospital following bypass, I've been present when people are intubated. It's another thing that Hollywood kind of has a very kind version of. Yeah. And let me tell you, until you've gone through that, you don't know why people get DNRs. It is very serious. Having to go and get your heart operated on, and exactly what you said, you will never be the same after that. It's a major surgery. As routine as this might get, as good as the survival rates may have improved to, you gotta care about your ticker. You just gotta.
Yeah.
You really need to keep from getting into that state. And so that's why your book title is great. It's a great book title. Stay off my operating table.
That's the message.
You'd like to just turn off the lights and be like, no customers anymore. What am I gonna do?
Yeah, exactly. I hope we get there.
6 or 8 hours without a bathroom break, you do surgeries for that long of time. Is that right?
Yeah, it's not the routine, but sometimes it ends up that long.
There's got to be a strategy to that, right? Like, do you chug well beforehand and then make sure you do enough bathroom breaks right before you go into operating? Is that how that works?
I think it's kind of a learned behavior. I wish I could say I was that strategic. This is one of the interesting things, though, about contrasting my life as a heart surgeon before low carb versus after low carb, the ability to deal with all of that stuff, right? The hunger, right? That I used to, right? It was a very real concern, right? I'm going into the operating room for, 4 to 6 hours, what am I going to eat before? What am I going to eat after? Being hungry in the operating room, right? Versus now, I mean, it just like...
Yeah, when you're fat adapted.
It's no problem, right? I routinely fast 16 hours a day, so, no big deal. It's a very real difference, the mental sharpness, the mental acuity that people talk about with this. I am in a profession where that has a very real difference. Probably, there are probably some examples that I could go back to that, maybe that made the difference between the patient, coming out of that operation well versus not well. I now, and again, contrasting my 25, 30-year-old self who was pre-diabetic and morbidly obese, but 20 years younger than I am today. And I truly do feel I can perform better in the operating room today, than I did 20 years ago with those long operations, with those, difficult circumstances. So it's just another example of the power of being healthy, metabolically healthy, that I see the impact of every day.
I look back, gosh, that's what, 20 years practically. I look back to my wedding pictures. My wedding pictures, you can tell I'm younger, but I'm also just heavier.
Yeah.
And same thing, I just am happier, healthier. It sounds self-evident, but I often make this as part of my pitch to other people. There's a spectrum when it comes to low carb, but just getting lower carb, if, again, part of your problem is a carbohydrate intolerance, is something worth considering, because you may not realize just how much feeling better becomes its own incentive. It may sound self-evident, but it really isn't until you've gone there. A lot of times what I'm trying to do is I'm trying to talk people into just giving it a phase or a trial period. Often 30 days. I just pitch the 30.
Yeah.
You can do anything for 30 days. Do this for 30 days. You can eat whatever you want on the 31st day. But let's get blood work at the beginning through Own Your Labs. Let's get blood work at the beginning, get blood work at the end, and do the comparison of the blood work. And a lot of times what friends of mine will say is, well, I can't get my triglycerides down. It just is what it is. I think it's a genetic disease or something. I'm like, just give me like a little bit of time. Let's find out. One of the things I like about low carb, getting back to one of the challenges with processed foods, or at least a lot of types of processed foods, is that if you're eating whole low carb foods, it's difficult to overconsume them. So if you're having, a big steak, it's very hard to overconsume a big steak. Try it. For an eating contest with somebody else trying to eat a lot of steak, it's very difficult to overconsume a big steak. And if you did have a very large steak, it probably will last you for like another, 16 hours, 20 hours or something. That actually happened to me once. I really wanted to, it was one of the most delicious steaks ever, and it was really expensive. And I just genuinely tried to eat as much as I could. Spoiler alert, I didn't succeed eating all of it. But I ate so much that I didn't want to eat for 24 hours. Spontaneously.
Yeah. No, it's a very real effect. And, it's interesting. I, as a clinician, sort of struggle a little bit, right? Because, I love getting all the labs, right? And I love doing that deep dive and showing the patients, this factor and this factor. But in the end, the most powerful thing is just eat like this for 30 days and see how you feel. And really, I think that's what keeps more people doing it, right? The reality is that most people don't walk around every day thinking about their triglycerides or thinking about their A1C even. They're thinking about how they feel as they go throughout the day. And the difference between how they feel when they're metabolically healthy versus when they're not metabolically healthy becomes the most powerful, selling point of this approach ultimately. And it's what people generally, keeps them sticking to it. Because I think what happens often is people, right, you say, go do this for 30 days. And they're very enthusiastic and they're motivated and they do it and they're like, I feel great. And they're like, I'm going to keep doing it, right? And then they hit a point where it becomes sort of the routine. And what happens is we then sort of stop thinking about it. And so we slide back to old habits. But then they notice even more, right? How bad they feel.
Right.
And again, this was something I experienced, right? Going through my life, before I went low carb, I don't think I fully realized how bad I actually felt. Like, I went through my days and I would get pretty tired in the afternoon and have to have a bunch of coffee, or I'd go take a nap in my office after surgery, right? But this is just normal, right? And things hurt when I got up in the morning and, all of this stuff that we think is normal.
And we can't stress enough that why you think it's normal is you have a whole bunch of colleagues
that
are in the same state.
Exactly, right? Exactly. Everyone else is unhealthy around you. And the most powerful thing, right, when I, did low carb the first time, I'm like, I feel great. Right? I'm not tired in the afternoon anymore, right? And this is even before like the big weight loss or anything. People notice those effects much earlier. And then, when I did have those slides back, right? And it's like, oh, I really feel like crap now.
Right.
It's interesting. This is another sort of thing that goes on, within the community, right? And everyone's like, well, if you only can feel good when you're on a low carb diet, right, and you can't tolerate this other stuff, right, are you really healthy, right? People kind of have this argument that like,
I've never understood that one.
Yeah, no, neither do I, right? That's exactly what I'm getting at. I'm like, this is the signal from your body, like you shouldn't be eating this other stuff, right? And people will make this argument like, well, but if you can't tolerate eating that other stuff without feeling like crap, there must be something wrong with you. And it's like, no, this is like how human beings are like actually supposed to exist.
This is by the way, asymmetrical with medicine, because often I hear these arguments, frankly, from doctors, which makes it worse to me. If the doctors themselves are fans of, understandably, medication that makes patients feel better. And you're like, because if somebody said, oh, well, you clearly have a problem if you need this medication to feel better, the doctors would be like, well, wait a sec. If it does work for that patient, it's efficacious, why are you trying to discourage the patient from being on this medication? Well, by the same token, if you get into a state for which the ketogenic diet or even just a low-carb diet you find to be beneficial, and you're like, I do miss being able to have my hot fudge sundaes, but that's all right. I feel better being on this diet. And then somebody's coming in from the side door and going, it must not be that good, though, because you seem to need to be on it in order to feel better.
Yeah.
Who cares?
I know. It's again like logic that I don't get. But as I was saying, like that is what I think really keeps people on it. All of the labs and the scans and stuff, they're interesting. But more and more people come back to, I just feel better. So why would I stop doing this?
Why? We never got into why you decided to go low carb. What was the catalyst?
So my journey into low carb, so I was, I was overweight, morbidly obese, actually. I was pre-diabetic. But I didn't realize low carb was an option, right? I was in that camp. I had literally never really heard people talk about low carb diets, right? I knew eat less, move more. And I had done that a bunch of times. You'll appreciate. So I was I was in the last year of my surgical residency, and I decided, I needed to lose weight, right? Again. This was right when the Palm Pilot had come out, and I got, I don't even think we called it apps, but I had something on my Palm Pilot that I could track my caloric intake, right? So I started doing that, right? And I set my calorie limit, and I made an effort to go to the gym as much as possible, and, lost a bunch of weight. And lo and behold, like so oftentimes happens, within a year, I had gained back the weight and more. So, I had lost weight a bunch of times in my life, but here I am. So I was, early 40s, a couple of young kids. My wife, after having our children, was struggling with heartburn and, a bunch of other sort of, things, and happened to see it was actually an acupuncturist that she was seeing just for, musculoskeletal, whatever type stuff, and said, you really should try cutting out gluten. And she comes home to me and she says, I saw the doctor and said, I should cut out gluten. And me, being the heart surgeon I am, said, well, that's pretty ridiculous. You don't have celiac disease. Like, why would you cut out gluten? And she said, no, I think I want to try cutting out gluten. So I said, okay, well, I'm a supportive husband. We'll try cutting out gluten for, a little bit. And this is, this is probably 2013 or so. So cutting out gluten meant unintentionally going low carb, because they didn't have all the gluten-free stuff, right? We stopped eating bread. We stopped eating pasta, basically. And, probably after a week, I was like, I feel better, right?
Right.
The energy was really the first thing I noticed.
Right.
So I said, well, this is interesting. And, again, I didn't really think about it, right? We were gluten-free now. So a couple of months later, I am at a meeting, heart surgeons meeting, the Society of Thoracic Surgeons. And there is a guest speaker who's on the agenda, some journalist by the name of Gary Taubes.
Oh,
and
you were literally there.
I was literally there. And so I'm looking through the program and I'm like, why is there some journalist talking to us? What is and I forget the exact name of the talk, but he had just written The Case Against Sugar, right? So it's something about low sugar. And, it was one of those situations, you've been to the conferences, right? There's 3,000 people and you're like, this session doesn't look that great. Maybe I can go back to the room and, take a nap or, go swim in the pool. But for whatever reason, I stuck around for for his talk. And, Gary being Gary, gives a great talk. And I was like, sugar. Why haven't I heard of, why is this the first time I'm ever hearing about a low sugar, low carb thing? And I said, I already cut out gluten. I'm sort of already there. Maybe I'll give this a try, right? And I bought his book and I read the book on the plane home. And then I read, Good Calories, Bad Calories. And that's when I first said, okay, I'm low carb now. I'm going to go low carb. And, I, again, continued to feel great, lost all the weight. And now I was able actually to keep doing this, right? I'm 6 months in, I'm a year in, right? And I'm like, this is great. And that's right about the time that I started, getting on the internet and looking at low carb stuff and, started coming across some different things. I ended up going, and I think this is where we may have first met. Nadir Ali hosted a conference, and I said, oh, maybe I'll go check this out.
Yeah.
And that's, haven't looked back since.
Yeah. I remember I'd already seen you present before, I think in another video, something along those lines. And there was sort of just a kind of a broader expansion on the medical side of the fence with low carb doctors who were both pro metabolic health and somewhat skeptical with regard to cholesterol in particular. And Nadir Ali was certainly one. You were emerging.
Yeah.
And we haven't gotten to it yet, but you also launched a podcast ultimately, right? So you're also a podcaster yourself.
Yeah.
But that came a bit later. Am I
Yeah.
not mistaken?
Yeah, so the sequence of events for me was so I went to a few conferences. I was actually at Low-carb Boca, and, still a practicing heart surgeon. And I ended up, I think Tro was the first one I had this conversation with. And, I kind of went up to Tro, right? And I was like, oh, I've been listening to your podcast, find all of this very interesting. And he's like, what do you do? And I said, I'm a heart surgeon. And he was like, and you're here? I'm like, yeah, this is all. He's like, well, why are you in the audience? Like, you need to be up, talking and all of this stuff. And again, I wasn't really. So I was like, I've been thinking about, like, because by this point I had, friends and family, right, that I had told about this, and they had followed it, and they were having good, and I was like, well, yeah, I was kind of thinking about starting a little practice, just an on the side thing where I'll help some people. I'm like, how do I do that, right? Because I had been a employed heart surgeon my entire life, right? I didn't run a practice, right? I just worked at a hospital, and they did all that. And I'm like, well, how would I go about doing that? And Tro was great, and he said, go this software, he's like, you can do it online, you can just see people, and he kind of helped me get started. So I started the practice, and then shortly after that was when I had met this ghostwriter, and he said, why don't you write a book? And he's like, it will get the message out there. It's a way to kind of help promote the practice. So I said, sure. So we did that. And then what happened was, so to promote the book, I started going on a bunch of other people's podcasts. And then I had another friend who said, why don't you start your own podcast? And he does podcast production. And he's like, I'll help you out. So I said, great, sounds good. What do we do? This is a good one. So he said, why don't you just talk about what's in the book? He's like, just go start talking about what's in the book, right? So I said, sounds good. So I sit down to try and record my first podcast, right? And I'm talking about a little bit that's in the book, and I talk for maybe half an hour or so, and I send it to him, and he's like, this sucks. He's like, you can't do your own podcast. He's like, how about I interview you about what's in the book? And he's like, there's 12 chapters in the book. We'll do 12 episodes, right? We'll just do, chapter by chapter. I'll interview you and talk about it. And we did that. And that worked a lot better, and then he said, so then we got to the end of that, and he's like, what else do you want to talk about? And we came up with a few other topics. And then he's like, maybe we should start, bring on guests, all these friends you have, in this community. And so we started doing that. We just released episode 250. We've been doing it for 5 years now. And
wow.
As podcast, very few make it past episode 10. I think is the stat, right? And so that happened. And, as the podcast grew, the social media grew, all of that. And here we are today.
I almost started a podcast at least 3 times, maybe 4. In all those times, it was trying to figure out the right timing, what it was going to be called. But I kept seeing Joe Rogan, and granted, Joe Rogan is who he is, so he could just, people would show up. He's the largest podcaster in the world. But I wasn't so much just, jealous of his level of influence and the money and all that sort of stuff. Hats off to his level of success. It really was just this format. This format to me just has always made perfect sense. You just don't get the same kind of experience through a Zoom call. And that's the problem. The problem is, okay, but convenience level, that's easy. Just make sure the schedules line up, and you and any number of other guests from wherever they're at in the world, likely they already now have a good camera, they've got a good mic, and etc. Whereas having like a physically dependent location for a podcast is kind of a big ask. But more and more, I kept thinking maybe the reason I'm never starting this podcast is because I'm just not going to be satisfied with anything but this. Like, that's just the bottom line. So either I'm going to start a podcast or I'm not. But if I do, why not just give it the best shot I can? And so as it happens, they're not normally in the studio, but Mattis is in the studio with us, the sound engineer, who's normally on virtually, by the way, but helped to design all of this podcast studio. And I love it.
Yeah. I agree. Even though I do my podcast by Zoom because of the convenience and I'm rarely in one place, my dream is one day my podcast will get to this, and being in person, it is just a whole different experience. And, the podcasts that I've been on, that are set up like this, I think the impact is much greater, and the conversation is just
a better experience for me and the guest. It's clearly going well out there because our podcast has grown. Like, at the time that we're recording this, I think we're at 155,000 subscribers. And we're like 5 months old.
Yeah.
And we're like on 22 episodes, I want to say. With a footnote. We have an important footnote. And in fact, it developed again last week. So episode 10, as of this recording, episode 10 is not on YouTube. It's on Spotify, but it's not on YouTube. The reason why is the guest and I were chatting. It's Peter Ballestead is the guest. We were chatting on a topic I'm afraid to even say the word out loud, because what happened was the podcast was basically getting suppressed by YouTube. And I got a label on it and so forth. And I was like, wait a sec, it's not a bad episode. Like, I've seen plenty of things on YouTube where I would say, wait, this subject matter covered by this other person got a lot saucier. I thought it was actually a very disciplined scientific discussion. And I didn't think his position on the topic of interest was extreme at all. I thought it was actually very moderate. But this is where we kind of got tested for the first time, because not only were the numbers way, way, way down. I mean, I'm talking the podcast before his was in the tens of thousands. And then all of a sudden his was under 1,000 and was just like, barely there at all. But on top of that, all of the other podcast episodes, which were accumulating views on their own, all flatlined. And I was like, oh my goodness, what the heck? Thought, well, we'll just release the next episode. We're just going to have to stick it out. I released the next episode. It's flatlining. And I'm pretty confident at that point it's because of episode 10. So I reach out to Peter, and Peter was great about it. I said, I've talked to some other engineers in the industry. They say really your best move is to straight delete it from the channel. You can't even just take it private. You need to just delete it. I don't know how accurate what they were saying was, but sure enough, once I deleted it, it's like it lifted the curse.
Yeah.
And I past that point, I was like, well, that subject probably won't come up again, so it's not going to be that big of a deal. Last week, we released one with Ginny Middich. You know who she is?
Mm-hmm.
She's great, by the way.
Oh, yeah.
Awesome person. That episode we released, same thing. All of a sudden, a flat line, and all of a sudden, it extends the rest of the channel. We tried playing around with maybe the description had certain keywords in it or something, so we had a real milquetoast version and literally relaunched it a second time. Still had problems. So I bring this up because this is one of the downsides of having physical, podcasting, where now I need to be mindful of what I think might trigger the algorithm to be upset with us, right?
Yeah.
And that part I don't love. But I plan to diversify. Even though YouTube's kind of where we're focusing, means that we need to put a little bit more effort into Spotify and Apple Music and so forth, the other places where podcasts could be. But I don't know. We may also try some of the other platforms just to, keep it in as many as we can.
Yeah. Yeah. And again, it's, I think, something unfortunate within our environment these days, right? That these topics, can't be discussed, right? And, again, I mean, and you sort of go back to cholesterol as one of the earlier examples of this, right? That, it became an unquestionable truth, right?
Right.
Even when I think back, right? So I was in medical school from 1994 to 1998. Statins were kind of a new thing, right? They were, by that time, I guess they had kind of established their place in the market, right? But it certainly wasn't to the level that it is today around cholesterol lowering. But cholesterol lowering, as the treatment for heart disease was an absolute truth, right? I never heard about Dr. Yudkin, I never heard about Dr. Kraft's work on, heart disease. It was unquestionable that cholesterol was the cause of heart disease, and that if we want to manage heart disease, it has to be, just lower the cholesterol. I think back, right, if I had kind of raised my hand back then, right, I think, Nick Norwitz is a great example of this now, right, because he went through medical school, knowing this already, right, and was able to question it. And if I think back, like if I was Nick back then and I had kind of known that, these holes in the cholesterol argument and tried to raise them with my mentors, with the professors and all of that, like I said, it was an unquestionable truth. You cannot question that. And it's only now, right? I don't think your work, for instance, right, would have made any headway,
Yes.
30 years ago.
No,
right?
and this is part of why we're doing the documentary.
Yeah.
Like you establish the science over here. Okay. In a sane world, we're like, hey, we're published. Hey, here's the data. There you go. Scientific community. Do you want to propagate this? And we know they'll go, well, there's already this wealth of evidence that's over here that we think is more, established. So, yeah, I wouldn't expect it to be taught to you. Yudkin predates us.
Yeah.
By, I don't know, it was a century ago. Am I remembering this correctly? Yudkin?
No, he was around. Well, yeah, he was 1940s, 1950s.
Yeah.
About the same time that
so like
Ansel
80
Keys was
80 years ago.
Yeah.
And here we are in a diabetic pandemic.
Yeah.
Right. And you have to have Gary Taubes write this book that you saw on the case against sugar. Right. But that's where we're at. So yeah, getting it back to censorship. If we are going to be, you and I, if we're going to be podcasters, if we're going to be content creators, yeah, we have to kind of be aware that it can happen. But this new paradigm that we're in, I mean, it's exciting in many ways because we no longer are beholden to some distributor to get the word out, to get content out. The catch is that, as is the situation, there's not distinct, well-defined laws. There's not a clear and clean adjudication process. There's just these community standards, which is some amorphous, opaque, you'll know if you get stopped. And if you get stopped, maybe you can do something about it. Probably you should just delete it yourself and hope that the almighty algorithm takes pity on you and doesn't and lets you continue to post new episodes.
Yeah, and there's the challenge of, again, trying to get, we'll call it these sort of minority reports out there, right? When we're dealing with an overwhelming majority of data that points one direction. And this is, again, getting back more to the cholesterol topic. We have this overwhelming majority of data that points one direction, and that is believed to prove it, right? Even though there is a minority of data that starts to poke the holes in that argument, right? And again, a good scientific discussion is supposed to consider both of those. But overwhelmingly what we see today is just, it's got to be true because all of these people say it's true, we'll call it. All of these, there are, however many thousands and thousands of papers, right, that support the lipid hypothesis. And the fact that there are a few that, contradict it or poke holes in it, right, that doesn't mean that it's not true in medical world, right? And this is what I find so fascinating, right, about talking with you as an engineer, because in engineering world, right, the black swans, they're the whole story, right? They prove that the rule isn't true. But in medicine, we kind of just ignore that, right? And say, well, all swans are still white, even though there are some black swans over there.
Yeah.
Those are anomalies. Those are outliers, right? And
it's frustrating when a word like paradox is introduced. It's just kind of a way to hand wave.
Yeah.
It's be like, the paradox of the black swans. But all swans are white.
Yeah.
Wait, you can't say all swans are white since there are blacks. Well, again, I already acknowledged the paradox.
Yeah.
Right? It's a way of saying miscellaneous. But to this larger topic of cholesterol, I'm coming in from the outside. Before I was publishing anything, I'm doing searches. I'm seeing that indeed there are all these things that seem to support it. The me of today knows now what the me of then didn't realize, which is that there is a direction the wind is blowing. There was an undergrad I talked to, I want to say literally 2 years into this, and I was trying to talk them into more research with lean mass hyperresponders. It was shortly after I designated the phenotype, and he was very interested. And he said, but I can't like actually do this at this stage in my career. I was like, well, it's the perfect stage in your career. You're budding, you're new, help me to get some of these labs, interested in this topic. And he goes, no, I think that they will believe it's only going to likely hurt the lipid hypothesis. And I'm naive me. I'm going, well, that's the prevailing hypothesis, right? Like isn't paradigm shattering like the basis of science? Like, don't you want to find a discovery that rewrites the things you know? And he was very candid with me, and it was kind of like, no, I need to be doing the opposite. I need to be building on my resume. And he called this a resume. He called this a resume building paper. He was working on it right now. Resume building paper. His words with regard to something that was supportive of the lipid hypothesis. Because the more that you're kind of establishing that you're, in the right way, especially if you can bring novel insights that are in support of this larger structural hypothesis, the whole field is built on.
Yeah.
Phil. The whole field, then you're part of the wind. You're going with the wind in the direction that it's going, right? And I don't bring this up to suggest that there's this conspiracy of a bunch of these kingmakers, meeting in a dark room every morning to get us all going on statins. It's not so much that it's a conspiracy. I do think it's an ecosystem. I do think there's a broader awareness of what the expectations are that has a feedback loop in and of itself. So that when something pops up and it's like, this is not supporting the broader hypothesis, there's sort of a natural, almost knee-jerk level of disbelief, because that can't be right.
Yeah, this is a very real thing, right, for most practicing doctors. The realization that I had to come to, right? That the disease that I had dedicated my career to fighting was not what I was told it was, right? That's a massive shift. And, and you can take it a step further, right? And, and this part I might be a little bit more insulated from as a surgeon, right? Because admittedly, as a surgeon, I had short episodes of care with patients, right? I did their surgery. I got them through the post-operative period. And yeah, I might say things like, yeah, you should continue on your statin, or you should, think about a low-fat diet, right? But, when you as a physician have to admit, right, that was wrong advice, and then think about all these patients that you've maybe unintentionally harmed, or at least didn't make them as good as you could have made them. We can say, maybe more, it would be a better way to say it, right? But if you're a doctor who's gone through your career, right? If you're a cardiologist, if you're a lipidologist, right, who has gone through your career, and this is essentially the only thing you tell patients, and it's wrong, right? That's a pretty massive, thing that you have to contend with as a physician.
That's one of the stories that I've discussed on here and that I plan to talk about in the book. Is there's a doctor who I genuinely think is a great doctor. I mean, really kind-hearted, and he conceded this to me. He said, I actually, this is after multiple great conversations. He said, the more that I've chatted with you, the more I think you might be right about this. But I got to be honest, I'm kind of rooting for you to be wrong, because the cholesterol lowering was always a big win. It always felt like a big win with him and his patients. And it's another place where I feel like maybe it's a different inherent attitude with us engineers that, oh, you were giving me wrong advice, but it was based on what you already understood by that point in time. Okay, yeah, that's fine. Thank you for letting me know. My bigger gripe in general, but particularly when it comes to science, is a lack of course correction. To err is human.
Yeah.
Right? That's fine. If you do have a lot of accumulating data that should, inform a new opinion, I really want that to happen. Not just for you, but for all of us, right? There's no reason to feel a level of buy-in with whatever your worldview is, that the contrarian data that keeps coming up that's challenging it is not something that you can incorporate.
Yeah, and that's how the monumental shifts happen, right? And again, we can see so many examples of this, right? I think about driving, right? And I think about, okay, we spent all of these many, many years, right, thinking about how we make driving safer, right? We make the cars better, and we put airbags in, and, all of the safety systems, right, that are in the car. And then, Elon Musk comes along and says, well, what if the cars just drove themselves, right, and can do it, orders of magnitude better than humans can? And and of course, when he first started saying this, everyone thought, well, that's crazy. You can never do that. And here we are, where I think it's becoming apparent that it's going to be true, that it maybe is true. And now it's just a matter of getting everyone to accept, right, that, this is the way of the future. And, the really big things that happen in medicine, again, going back to, John Gibbon thinking he can, design a machine that will take over the function of the heart and the lungs so that we can, save all these patients' lives and operate on it, right? And, I'm sure everyone around him said, you're insane, right? And, 20, 30 years in the lab trying to do this, right? And all of the failures. But it's only when people take those big leaps that we get these, monumental shifts. And I think, really heart disease is at that inflection point. We can keep going down the same pathway, and maybe we can make it incrementally better, right? With here's the new medication and, this and that. or we can step back and say, we've been doing this experiment now for 70 years. The results have been quite disappointing. Maybe we should change shifts. Maybe we should change focus, right? Shift our focus, and maybe we can have monumental impacts, right? I talk about how my dream is that heart disease will no longer be the number one killer, right? We've been doing this for 70 years. It's still the number one killer, right? We're really not gaining any ground. We should be able to really think bigger and say, we can make heart disease not the number one killer anymore. And I think that, metabolic health, insulin resistance, right, is the way to do that. And okay, we'll start looking at some of the other tools. Maybe it's not all about our diet. I think our diet is a big part of it, right? But I can also see now, okay, we have these GLP-1 medications that help with insulin resistance. So maybe these are a tool that we think about how we integrate into, what we're doing. But the first thing we need to do is we need to change that focus, right? And again, you and I have discussed, right, the evidence that we have that the magnitude of effect from insulin resistance on heart disease specifically
so not even close
to cholesterol. So let's just start focusing on that. And again, I'm optimistic that maybe we're starting to see the conversation shift that way. When I do talk to my colleagues and I say, okay, cholesterol is cholesterol. What about insulin resistance, right? And it's really not that hard to okay, you're sending off the cholesterol panel. How about you send a fasting insulin level as well?
Yes. Oh
right?
my God.
Or maybe, you're a cutting edge lipidologist, right? So you've gotten that advanced lipid panel and you're looking at the small particles. And how about saying, okay, if we could lower what is driving these small particles, it's insulin resistance. So maybe if we fix that, the small particles that you're worried about, they go down, right? Maybe that's a good thing. Let's just start bringing this into the conversation. And I think that's the way, and no, I'm not expecting that, the American Heart Association is going to have the big press conference and say, all that cholesterol stuff, we were wrong about it, right? That's not going to happen.
Right.
But maybe 10 years from now, we find our place, right, where, those case presentations that are being done at the American Heart Association meetings that you were talking about, or the Lipid Association meetings, right? They're all about how we fixed insulin resistance and not just focused on how we lowered the cholesterol.
I've wondered how much these GLP-1 agonists are kind of forgive the term, a gateway drug toward the broader recognition of metabolic health.
Yeah.
That's what's fascinating is I think everybody who I've chatted with for this podcast has mixed opinions. It's generally a net positive, especially for challenge cases. I can see this myself for my challenge cases in my life who they're saying, listen, I need it in some form of a pill or, an injectable in order for something to happen for me. Otherwise, because I'm just not going to give up my way of eating. I'm not going to give up my lifestyle. That's just who I am. From their perspective, that's what they would say. And for those folks, I'm like, well, I'm glad there's something that's new that you can. For those who seem to want to make lifestyle changes, but to find that it's difficult, but that is in fact their core desire. I hope, and I've said this to them, I hope that it's a jumpstart. Dr. Boz, who I'll also have on here too, she's got a great program where they do microdosing because it can be argued that the dosage is too high.
Yep.
And that there's a lot of downstream negative side effects for how high a dose people are taking. That sounds attractive to me for them, for these people I'm talking about. But ultimately, the key component is for there to just be an awareness that metabolic health improvement, even if it came through a pill, might demonstrate an outcome of relevance so that at least it lives in hard data. of what's in the peripheral view. Because how can I get your colleagues to see metabolic health? How can you get your colleagues to see metabolic health and its distinct relevance, not just on all-cause mortality, but on cardiovascular disease? We put it in a form that's a medication, and now you can actually see efficacy and you can see outcome data. Then it's sort of like, hey, now let's talk about what if we didn't have the pill or the injectable, and you could talk people into the same outcome that you'd get from these GLP-1 agonists in that fashion. How great would that be?
Yeah, no, I think that's exactly how I think about it. And, we're using them as well. And, oftentimes I agree with Dr. Boz with Annette on this. The problem is the dose and the problem is the strategy, right? That this is the only part of the solution versus this is a tool while we're doing this other part of the solution to help you implement it and to augment its effectiveness. And I think it is a gateway. That's why I am enthusiastic about them, because it's bringing it into the conversation. Again, I don't agree with the majority of the way that it's used out in the standard medical practice, that this is just the solution to the problem. But I think it can be a very useful tool. And I think it does open up that conversation of, okay, we've now demonstrated that these things reduce cardiovascular risk. They don't reduce cholesterol, so how are they doing that?
Right.
There's this thing called insulin resistance, right, that they act upon that's reducing cardiovascular disease. What are some other ways that we might be able to reduce insulin resistance? I think that's more and more how that conversation is going to go, and I think it's going to ultimately lead us to a better place. Like I said, it's not the total solution. It's not going to get the cholesterol out of the discussion. And again, you and I agree, right? Cholesterol isn't meaningless, right? We do need to talk about cholesterol. The way that I view it is we don't talk about it in the right way. We should talk about the quality of your cholesterol more so than the quantity of your cholesterol and the environment that the cholesterol is in.
Yeah. So we'll drop in there for a little bit of nuance here. Yeah. I tend to find that if I'm speaking to a regular lipidologist, then it's ApoB, ApoB, ApoB. So the number of ApoB containing lipoproteins is going to be the most relevant component toward the progression of atherosclerosis. This is part of what our study is providing a lot of value for, because that relatively simplistic version of the lipid hypothesis would suggest that lean mass hyperresponders are a high-risk group by definition, full stop. This is where our data is going to be very valuable, because not only is it testing that, but it's also seeing how much there's an association. And spoiler alert, as of right now, our data is pretty strongly showing that no, there's no association. If I'm talking to a low-carber circa 2016, 2017, so forth, it's about the small dense versus the big fluffy. You alluded to something that I myself would have double-clicked into, which is, wait a sec, how do you end up with the higher preponderance of small dense LDL particles? Metabolic health is directly associative to that higher proportion of small dense LDL particles. Let me state this a different way. If I give you poor metabolic health, you will have a change in your lipid profile. Your lipid profile will change. Now, this is the definition of a confounder, right? If a thing such as your insulin resistance actually affects two other things, your lipid profile on one end and your cardiovascular disease risk on another, it's difficult for us to then disentangle what the relationship is between these two. So your lipids and your cardiovascular disease risk, having this confounder in place, make it difficult to come back to the thing we were talking about earlier with things like adjustments.
Yep.
How can you make an adjustment unless You get these two away from this, right? Okay. So now we get back to the quality of the cholesterol and the way that you described it. So you might be, I think what you mean by that is the quality of the particles themselves. So
Right.
for example, this gets away from ApoB, this gets away from small dense versus big fluffy. There's now modified LDL particles, such as oxidized LDL or glycated, some way in which it's modified, right? For which there are a number of people in low-carb space who are focused on that, ox LDL. I'm interested, for example, in something called phospholipid ApoB. What do I want to say? Ox phospholipid ApoB is what I want to say, yes.
Yeah.
Also very fascinating, very interesting. But at the end of the day, my position is not so much that I'm going to express confidence this is exactly what it is, so much as I'm going to say I want to put on the table that all versions of the lipid profile in its association to cardiovascular disease may be predominantly about the state of the body and the impairment or dysfunction related to the lipid metabolism as to why there's that association between it and the development of atherosclerosis. That's thing one. Thing two is there a part of the causal pathway, ApoB lipoproteins and atherosclerosis? Yes. Can both of these things that I just mentioned be true at the same time? 100% they can both be true at the same time. You can have a systemic problem inside your body that, again, both changes your lipid profile and is an independent risk for cardiovascular disease. And we already know this from, say, the work of Brown and Goldstein. Children with homozygous FH, if they bring their LDL levels way down, are they still at a greater independent risk compared to other people of this same LDL levels? We already know they are.
Mm-hmm.
We know that. Now, I want to be fair. A lipidologist would say, well, there's maybe more things with regard to how they're developing when they're very young or something like that. It's possible. But right now, homozygous FH is incorporated into these meta-analyses like the famous 2017, consensus paper, making the case that no, it is the LDL, it is the ApoB. That's how it's presented to us. That is what distinguishes them. It's not these additional factors that are brought in later as an explanation as to why there's that independent risk factor. So all roads, in my mind, lead back to lean mass hyperresponders. We had to get a population that didn't just have elevated LDL, but like many in our study, have sky-high levels of LDL. We have 6 people with an LDL of 400 or higher, right? So their LDL, their ApoB, and Philip, small dense LDL particle absolute numbers can actually be higher in these folks. The absolute numbers, even if the proportion is smaller.
Right.
So if we're going by absolute numbers, which would be, per the lipid hypothesis, their absolute number of small dense LDL particles would be higher. You would then think that this would show itself through the development of plaque. You would think that there would be an association. But do we see that? So far, the answer to that question is no. Across 4 analyses. Our study has 4 analyses.
I'm waiting for you to publish that piece of it. But
yes.
Yeah, no. And again, I think there's literature already to support this, right? The proportion of small dense versus the number of small dense,
Yes.
Difference there. And that's really what I, now talk to patients about being your cholesterol quality. And it's challenging, right? Because you get the lab report and, it's the red number, right? For the small dense, right? And the ApoB and all these things are red. And, here I am trying to explain to them, but, it probably shouldn't be red because of this, right? And again, it's not something I made up. It's in the literature, right? The proportion of small dense LDL is more predictive, right? And again, associational, yes. And maybe there are some interesting populations that we could look for to help us, right, along the same lines of the lean mass hyperresponders. But the proportion of small dense LDL as of your total particle count is a greater predictor than the number of small dense particles.
Right.
And again,
but that's a huge deal.
Right.
Like what you're saying right now is already at odds with the present lipid hypothesis.
Most lipidologists would say, no, that can't be true.
Right. They would say, listen, if you know the count of the ApoB, you know the likelihood of the development of plaque. And the bottom line is, if that's true, that would be showing up in our study.
Yeah.
Particularly if we, as I'm hoping, will get the 5-year scans. We'll see about that. It may end up having to get pushed to 6-year scans. We'll find out. Hopefully I can preserve the sample size. I'll take a moment. This is the benefit, Philip, of us being in person.
Yeah.
I'll take a moment to say what I can say at this moment in time with regard to our study. We're recording this mid-February. I'll just mention that real quick. Hopefully by the time that I'm publishing this, this will already be news that's out. If not, there'll be an edit point here. I'm looking over at Mattis in this moment. Here's the deal. The deal is we got the Clearly data set. I don't know how much you've been following. Have you been following pretty closely?
Yeah.
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 So we get the Clearly data set. A lot of this is already now pretty public, but it's anomalous. And it's only after I get the raw anonymized data do I find a number of things that were not identified before. And then a very lengthy back and forth is going on behind the scenes where I'm pressing them to do a fully blinded reanalysis of the data set. It later comes out that, in fact, it wasn't fully blinded. The initial pass, so we didn't ever even get the original initial fully blinded pass. We get a heart flow analysis, which is a competitor to Clearly, but that one's operationally blinded. And the patterns of their data match what it was that I thought were problematic patterns that I identified to Clearly before we got heart flow. I'm totally speed running this, by the way. And then we finally get the pre-specified METIS-Q angio.
Mm-hmm.
You're already familiar with all of these.
Yep.
In fact, you yourself are using one of them now.
Yep.
And this was one of the interesting things to come out of this for me is I don't know that I think that there's a problem with any of these 4 analyses, and that includes, I don't know that I think there's a problem with any of these 4 processes and how they conduct their analyses. I just know that the data set that was delivered to us itself from Clearly for our study has some very glaring anomalies, in my opinion. The lawyers will want me to say in my opinion. But it took the accumulation of a lot of these other data sets for us to then further press behind the scenes for this to get resolved. Only after we did literally just about everything did we need to decide on this next major step. The next major step is in development now. It's like, I can't say it out loud, but you can probably tell what's coming. But I was quite adamant, beyond the fact that the detractors would understandably be concerned if it just looked like we were casting that data set aside. We needed to do our dewest of due diligence before pressing further. Beyond the supporters wanting to get the data, there's me in particular, Philip. I feel like this is something that's due us. I feel like we did everything we were told to do. What got received is, I believe, something that we can say, hey, all of our other teams would be willing to do a quality control check. Why are you guys not willing to do one, especially when this is unlike any other data set in all of imaging? By far. I've got a 24-point report on all of these different issues. 2 of them are already the easiest ones to communicate to a lay audience. You're probably already familiar with both of these by this point, but I'll just say them again. They're all progressors. There's not a single regressor, including at the lowest level of statistical noise. I don't know what that's about, and the other one being that those with a CAC of 0 had a several-fold higher increase in plaque than those with a positive CAC. Again, you being in the research, this is just highly implausible. So, at this moment in time, the reason this has taken as long as it has is because we did have to make a deliberate choice, and it was mainly my choice to make, which is, do we exhaust every avenue to try to get this quality control check, including waiting until these other analyses are in, because that would, apply a lot of pressure if indeed they all agreed with each other, which they do, and disagreed with this anomalous data set, to give at least every opportunity for this quality control check to happen. But there's one piece of this I can't tell you about yet. And it's kind of the final bit that brought us to the point we are now to basically determine that the clearly analysis needs to go. And that's going to be coming in a future podcast. I may be able to talk with you more about it offline.
Hopefully. But I guess, my perspective, right, as a clinician, right, knowing all this, hearing all this as it's going along, right, is, these are patients, right?
Yes.
These are people who are trying to make decisions on all sorts of aspects of what they're doing in life, right, based on this imaging. So it's important for us to know that the interpretation of the imaging is correct.
Yes, of course.
And if there are different interpretations, right? And this is something that I think patients maybe have a little bit of a hard time understanding. And quite frankly, even a lot of clinicians, right, would have a hard time, right? You get a set of pictures, a CT angiogram. They're there, right? They're physical pictures. We can look at them. How do you interpret those differently, right? Where does all this variation in how they're interpreted come from? I kind of understand it, as a clinician, and again, it's something that I probably in the past wouldn't have really thought about, right? But looking at it through this context, it makes it apparent to me. And, we as clinicians now need to struggle with, okay, well, which interpretation, or, how do I translate that back to this patient, right, who has a very real question? Is my disease getting worse, or is my disease not getting worse?
Right.
Right? That's the first question we need to answer.
And I feel like I can give a better answer today than I could before.
I definitely think so, yeah. So, and maybe this leads into another part of our conversation, right? This advance in imaging, right, when it comes to heart disease is just monumental, right?
Yeah.
And, you and I were at the Low-carb conference, a month or two ago, where it was a focus, right? That, okay, great, cholesterol is what it is. Insulin resistance is what it is, right? Inflammation. But what matters in the end of the day is we have a very real disease that I look at in the operating room every day, right? And now what I want to know is, okay, I have these patients who haven't made it to the operating room, is their disease getting worse or is it not? This is something very important that we should be tracking, right? And this is another thing that just, quite frankly, astounds me these days, that most cardiologists aren't interested in imaging the disease that we are trying to manage.
Yes.
Like even something like a CAC scan, right? That again, we in low carb world think is everyone has them, right? The majority of patients have never had this scan, have never heard about this scan, don't know what it is, right? And, they, again, are not looking at the actual disease. They're trying to look at all these surrogate things that may or may not predict your risk of the disease. And why don't we look at the disease more?
Yes.
So I think that in and of itself, right, asking the question in the way that you did in the study, right, that's saying, okay, we have a disease that based on this risk factor, we think should be getting a lot worse, right? Should be getting worse quickly if we think this risk factor is what it is. So let's look at that, right? And again, you're, as far as I know, essentially the first trial that even looked at it, right? Did CT angiograms 1 year apart, essentially, to see if the disease gets worse with whatever factor we think is influencing that. That maybe even more so than the particular aspect of, what's going on with lean mass hyperresponders, right? I hope that there are a lot more trials coming out, that flood the literature showing me what happens in patients on PCSK9 inhibitors doing CT angiograms 1 year apart.
Yeah, it's all right. Let's have fun with this, because I rarely have a guest like you where I can really kind of unpack this. These images, what probably a lot of people who are not familiar with these DICOM scans is, when you hear image, you think of something that's 2D. You're probably thinking of something like a chest X-ray, and you think somebody like you is like putting up a heart, X-ray. No, what these scans are is they're a series of images from multiple angles.
Yeah.
And what's happening is it allows for a 3D reconstruction of the heart. And with various softwares, you're able to effectively maneuver in with a cross-sectional slice from different directions to then examine these vessels you are extremely familiar with, because you have to understand the deep anatomy of the heart. And so they're very familiar freeways, if you will. And it's also how you can tell if there's an anatomical anomaly, right? Okay, so with that said, there's also a broad understanding of where likely places of plaque will accumulate, which is why the very first analysis that was done in our study is done in a lot of these studies, and it's called a semi-quantitative analysis. I like to lovingly call it the horseshoes and hand grenades version of it, which is that a reader, within a matter of, how long does it take? Like 10 minutes, maybe, something like that. It takes a very small amount of time. They're going through, with one of these softwares, they're going through and going to each of these predetermined checkpoints, places where there's bifurcation or where there's other turns of shear stress, for which there is a likely, there would be more likely a place of accumulation of plaque relative to other areas in the coronary arteries. So they're going through, they're spotting it, and then they give it a score between 0 and 3. So it would be just like if we went outside in Las Vegas and we knew where there were common places where there's accidents in the freeways or in the different roads, and we go check those corners and we're like, oh, it seems like this time around we're in fairly good repair. So this is happening with all of the 200 hearts, or the 200 scans, I should say. It's 100 hearts, 2 scans per heart. So that's done. That's called a semi-quantitative. When we bring in the quantitative analyses, they're bringing this promise that you're very interested in, that all of us are very interested in, which is they say, we've got something better. It's more granular. It's tighter. And it's more automated. That also brings us the sense that we feel more confident it's going to be more objective, right? But here's the catch. There's a little bit of a black box effect to it. It's using things like AI. And it's saying, trust us. The training on this is against a whole bunch of other studies. And so we can know the difference between these scans, because they're not super, super perfect resolution. Sometimes they have little bits in it for which you're going, wait, is that an artifact? Is that something with something with the scan quality? Is it something that's in the blood? Or is it in fact like a soft plaque that's over here, right? And it does its best to interpret that. However, as with all forms of measurement, there is a point where it becomes noise. And by noise, I mean it's difficult to interpret. The resolution of the measurement is becoming lower, right? Okay. That's going to be very relevant to this next thing, which is at the point that we were recruiting, we didn't know how low a plaque these folks would be. Spoiler alert, they're low as a population. Our cohort is very low, average, baseline plaque. By the way, this is something detractors will agree with as well. Low baseline plaque. So the follow-up scan.
Although that in and of itself should have been a monumental finding, right?
Right. So average of 4.5 years on a ketogenic diet at these levels of LDL of like 254, I want to say is the median average, something like that. But with low baseline plaque.
Yeah.
Okay. So recognizing everything that I just said, there's an important component that for people listening closely should be very aware of. These DICOM scans, they're capturing the heart in a moment in time, but they can't successfully capture it in the right moment in time so that it is always in the right shape to compare to a second DICOM scan that's going to be taken a year later.
Yeah.
That cannot be understated. The heart is a moving target, and therefore the plaque and the coronary arteries around it are also moving targets along these vessels that are conforming and changing in shape.
Yep, exactly.
That's a big deal because what cardiologists and surgeons at these conferences, what they like to show are these AI generated, they look like the vessel and it's nice and long. Those are computer generated facsimiles of what the vessel looks like. And when there's a lot of plaque, you can feel confident that it's a pretty good facsimile. So when there's a stenosis that's coming in, it's a little pinch, right? I can say, yeah, I believe it because that's not hard to detect. The levels of plaque are easily detectable. And so it's something like a scan rescan in a study. I can feel confident that that's going to be accurate, right? But for us, for our study, because there's low baseline plaque, there's even more focus on those artifacts for the smaller bits. And that's a big deal for something that's talked about a lot and not just low carb, but everywhere, which is this issue when you have a low absolute number, the relative number becomes potentially much noisier and a bigger deal.
Yeah.
And that's why when we get the second set of scans and our first quantitative analysis is clearly, and for the low levels of plaque, clearly comes back and they say there is no noise such that there was any regressors for the second set of scans. I can say that seems so implausible because even if you believe in the lipid hypothesis and you believe all of our people should have only had progression, it's so low in the baseline that there should be at least noise outshining the absolute levels of progression. But it's even worse than that. There's a 50% increase relative to the first baseline scan in the Clearly analysis. That made no sense to me at all, because what you're saying is the average 55 years of the lifespan of our cohort, the average 55 years, we just happened to catch it in the 1 year where the average moved up 50%.
Right.
Somebody like you knows why that's biologically next to, I have to use the word implausible or the lawyers will get mad.
Yeah.
But 100 people having an average 50% increase in their plaque levels was absolutely, I just couldn't believe it as I was seeing it.
Yeah.
Right. But on top of that, the fact that there was no regressors in all of the things I just now explained to you, right? All of the aspects that create the difficulty of looking at these scans, to then have the second set of scans be ubiquitous in being both only positive calls and an average of 50%. That's what made it less usable, in my opinion. Now, bringing it back to you, Philip, you were one of at least 100 people that approached me and said, how do we make sense of what's going on right now? Because after the April 7th paper was released, many people like yourself were aware that this is actually odd, that the semi-quantitative data, which showed low levels of plaque change, even if it was horseshoes and hand grenades, would be so at odds with the Clearly analysis. So we still had the pre-specified analysis to come, the Q-angio. But thank freaking goodness that we were able to add one more. Because I think it would have been exponentially not as helpful, I'll just say, to have only one more analysis.
Right.
I wanted one additional, fully independent, operationally blinded analysis.
Yeah.
And that's what HeartFlow was.
Quantitative, yeah.
Yeah,
Fully
quantitative,
yeah.
AI-guided reading.
Yeah.
But that was observation. That was operationally blinded.
Yeah.
Which clearly refused to do for us. They would not do an operationally blinded quality control pass. And I'm just super thankful that we did that, because sure enough, then below the noise floor, below 50 millimeters cubed, we had about a 50-50 between those that were progressors versus regressors. Right? Yeah. Now, I know this is a very lengthy explanation, but bear with me. I'm bringing this all the way back home to, can the me of today, right now, mid-February 2026, speak in a more informed fashion back to you who makes use of AI-guided reading for making that determination, are you increasing plaque or decreasing plaque? And I'm going to tell you that given what I know in this moment, I don't know how much I would trust a change of less than 50 millimeters cubed in plaque as definitely not being noise. And that's because of all the stuff I just explained to you. The problem is that I know these AI companies, they're not going to like me saying that.
Right.
Because their business model is based a lot off of making the assertion that they can pick up plaque levels. I myself have said it because I'm going off of what they've told me. They can pick up plaque levels of as little as 1 millimeter cubed or less. That can actually be true, but how certain of it can we be that it's true?
Yeah.
That's the crucial question. When you're working with a population that already has low baseline plaque, my confidence level that you're going to pick up a change is reduced because the resolution is just so low.
Right.
So let me just qualify one more thing, which is when I'm talking about that, I'm talking about something called SDC, which is what I'm going to do my talk on, or smallest detectable change. So the best way to state this is to say, what amount of a change can I feel a 95% or greater level of confidence is in fact a change?
Right.
And for HeartFlow, I'm kind of going off the top of my head. I want to say it's something like 60 millimeters cubed. And that's the one data set that I trust the most for its level of operational blinding. For anything else, if you're concerned that they're using functional blinding and that they may be overcalling towards, say, the positive, then that reduces the smallest detectable change artificially. You see the problem?
Yep.
And the reason I bring this up, Philip, is because this can potentially apply to the entire field. There may be an artificially high level of confidence in the degree of detectable change of plaque by these systems. And that scares the engineer in me.
Yeah, and there's I would say even more maybe nuance than that, right? When you actually are looking at these images, right, and with patients, right? So there's a couple of things that I've observed. Again, I have a bit of a unique practice. When my patients get these scans done, right, I don't just get the report, I get the pictures. And we look at the pictures together. And you start to notice a few different things. So two interesting things, and I can draw upon recent patients that I've seen, right? So one thing, I guess, going back to all the controversy around, the first data set release, right? And everyone zeroed in on the percent atheroma volume, right? Because this is felt to be one of the, best measures, right, when you're using these studies. However, there are some challenges, right? Because percent atheroma volume, right? What it means is the total volume of your plaque divided by the total volume of your blood vessels. And there are two variables there, right? But we don't realize that one of those variables, we think it's fixed, but it's not, right? The total volume of your blood vessels, like you said, blood vessels are conformable. They're expanding and contraction with the heartbeats. They're, bending, right, as the heart is bending, and where you catch it in that cycle, or, maybe physiologic changes that have occurred, right, are going to affect your blood vessel volume, which is now going to affect your percent atheroma volume. So I have had patients, right, that demonstrably they have a lower plaque volume, but they have a higher PAV because their blood vessels shrunk, essentially, right? These are changes, and especially when you're, again, dealing with those low levels of plaque to start with, right? That change in the blood vessel volume might magnify things. Even more so, what I've noticed is, so we get these reports, and it has, how much cubic millimeter of plaque is there and percent atheroma volumes. And then they will report, right, and they segment the blood vessel into, what we call proximal, mid, and distal, right? So you basically take the whole length of the blood vessel, divide it in thirds, and they report the greatest stenosis within each of those segments. And this is something very interesting I saw in a recent patient, right? So patient a year ago had a scan, AI analyzed, and it said in the proximal left anterior descending, the maximal stenosis was 81%. And then he comes back to me the next year, and we get the scan again, and, same analysis. And now it says the proximal LAD, the greatest stenosis, is 82%. Okay, so you're looking at the report and you're saying, well, maybe that's within the margin of error.
Can I ask, symptomatic?
Not symptomatic.
Okay.
Right, and so that's why we hadn't done an intervention or anything.
Sorry for the uninitiated. The reason I was asking that question is for the reason I'm sure you gave that opinion, which is that people can actually have an occlusion that may be even as much as 80%, and yet they don't feel any effects.
Right.
Correct me if I'm wrong, there's not data as it stands currently is that there's actually not a lot to support an intervention when the patient is asymptomatic, even in cases of an occlusion of that level.
Correct.
It used to be assumed.
Yeah, that if it was narrowed
above
that
50%,
much,
that you absolutely had to place a stent, that kind of thing. But there's not the data has since been no, there actually isn't enough of a reason to take steps, but to be aware of it, no question.
Yeah.
But okay, sorry, continue.
So you would look at that report and you would say maybe he's getting a little worse, probably about the same. Hasn't gotten better, right? And then we drill into the images, and what we see is, right, so this 81 or 82% blockage on last year's scan was probably, kind of hourglass shaped, and maybe that point where it was actually about 80% narrowed was maybe, let's call it about 4 millimeters in length, right? And then I look at this year's pictures, and that 82% narrowing was literally a pinpoint, and that hourglass had all kind of, opened up again, right? So looking at the pictures, the only thing I can conclude is this is an improvement, but the numbers don't reflect that. And this is an even bigger challenge, right, that's going to come into play, as you're trying to interpret all of this. But I still go back to, right, when I looked at the initial data set from the Keto CTA publication, right, not the Miami Heart publication, but from the Keto CTA publication, right, I still looked at it and said, these are people that have a lot less plaque than we expect them to.
Right.
And honestly, even for most of the progressors, it was noise. It was within the margin of error, or it was, a pretty minimal progression, right? If we're going back to the lipid hypothesis, right, that LDL levels of this level should drive pretty noticeable improvement, we're not seeing that.
Yeah,
that was my takeaway as a clinician, and again, I think it goes back to, right, how much more important the imaging is, but you got to be careful in how you're interpreting the imaging.
Exactly. Like I'm more bullish on imaging than ever. It may not seem that way from everything I just said, but no, I stand by what I said at Boca when I was there and you were there. Nothing beats the physical detection of disease. That's very prognostic. It's very predictive as to what your likelihood of future events are, right? And wow, we have the ability right now on a very low dose of radiation to track that predictiveness as it happens in real time, right? But for sure, if a good surrogate did exist for that progression of plaque, and that surrogate, is also part of the causal pathway, being ApoB lipoproteins, we've got the data set to help track that. Now, again, I want to be a good scientist. Maybe it's true that 4.5 years is not long enough. However, I want to sit down with somebody who's pro-lipid hypothesis and talk out the math, because the math, if you're going by, I'd already mentioned Brown and Goldstein many times over, they were looking at children with homozygous FH that had LDL levels, I want to say around 780, something like that, right? So in 3 years, symptomatic cardiovascular disease with like a stable angina, right? 3 years, so 3 times 780, you can do the math. 4.5 times, let's see, our person with the highest LDL was 595, something like that, far exceeds that. But on top of that, again, our cohort is an average age of 55. So you add the whole cumulative 5 decades before the final 5 years. There should absolutely be a sizable proportion of our cohort with symptomatic cardiovascular disease. And I'll go a step further and say that should we get the 5-year scans, would I expect that nobody has had any kind of heart disease or events or anything like that? No, in fact, I would state the opposite, that statistically speaking, what are the odds that there wouldn't be? If you grab any 100 healthy people,
50, well, especially if you grab 55-year-olds, right? You're going to see some heart attacks in 5 years.
Yeah, and you go to age 60, right? Even if they had low LDL, even if they were healthy at baseline, again, just by the sheer odds, some number of them are going to have advancing plaque and what may be symptomatic cardiovascular disease within a span of time. A handful out of 100 would not be that surprising, right?
Yeah.
Again, given a decade, right? So there's just a lot there. But the bottom line is, would we absolutely expect in a decade's time for there to be a clear association between the LDL and ApoB? A clear association. I don't know how you can put forward the simplistic version of the lipid hypothesis without that.
I think that's really the key, right? Because again, as a clinician, I'm not trying to say, right, that a low-carb diet, right, is guaranteeing you're not going to have heart disease, right? This is, I think, another very important part of this discussion, right? What this study is designed to show us is essentially whether or not this lipid hypothesis applies equally to people with this physiology, right? This low-carb metabolic health, sort of physiology. And again, as I look at the people in my practice and, the people in the community, right? No one, well, I mean, I can't say that categorically, right? But I don't think anyone responsible has tried to say that going on a low-carb diet is 100% protective against heart disease, right? Yeah. And there are clearly people within the community, right? There are some influencers now that have had heart events. And, again, me as a clinician, right, the default argument there is, well, of course it's because of their LDL, right? Or of course it's because they're eating so much saturated fat or red meat. And then, what I think is going to be most powerful, right, from the data that you're gathering is I can say, well, no, it's not.
That's why exactly.
So let's figure out what it is.
That's why you get it prospectively.
Yeah.
But let me reinforce your point. You're 100% right in that if you go low carb, not only are you not heart attack proof, but I'll comfortably predict that all populations are going to have heart attacks. Populations.
Yep.
That individuals, that changes it up. But find me any population of 55-year-olds that are not going to have heart disease, right? If randomly generated. And this is why you do prospective studies. These anecdotes where you're looking even unconsciously for the patterns that fit your worldview, that's always going to be a problem because we're humans. That's what we do, right? So if you don't believe in the vegan diet and you think low LDL is going to cause cancer independently, and those, sure enough, every time you see somebody on Twitter mention something, you're already collecting in your mind. But then eventually you have 9 that you've accumulated. Well, the vegan diet isn't some offshoot diet. It's not something practiced by just 5 people. It's actually a prominent enough diet that association wouldn't be that surprising, especially if you're choosing it a la carte, right? By the same token, and I predicted this the entire time, I think as lean mass hypersponsors, our Facebook group is nearly 15,000 people. I absolutely predict there's going to be heart attacks within the group. I absolutely predict that there is going to be case series that say a terrible set of examples of lean mass hyperresponders who've gotten severe advanced cardiovascular disease, right? But case series is by definition retrospective. So as the data set gets larger, what are the odds that you do not see a subset for which there's going to be cardiovascular disease? This is why you do prospective studies. You want to describe the group in advance, then recruit against the description for the eligibility, then study them over time. And that's going to give you much better data than what is going to be an unintentional or even intentional cherry picking after the fact. So yes, not only is being on a low carb diet not going to by default make you heart attack proof, being a lean mass hyperresponder isn't by default going to make you heart attack proof. All of us have some susceptibility to heart disease. But with all of that said, can we put some interest into the levers and how much does metabolic health matter? Yeah. Well, like in the case with our study, as you saw with my presentation, the gist of my presentation was this. How much could I find associations that people kept asking me for in the blood work? Well, of course, part of our eligibility criteria was a CRP of under 2, systolic and diastolic blood pressure that were below metabolic syndrome levels. So generally good ASCVD eligibility. After all of that, how much do we find that association in their blood work with regard to, it turns out to be this or that? And the short answer is none. Because guess what? Once you get metabolically healthy people together, those associations that are thought to be causal towards cardiovascular disease do not appear to have that association. Which brings me full circle back to the whole adjustments and the modeling and so forth. Until we put more effort into studying healthy populations, we're going to keep chasing our tails, in my opinion. We have to work at that. That's how you can look at something like LDL. Yeah. And again, I think that LDL has become such a distraction, right? That we don't look at anything else. So we can't,
find these things. I do find it interesting. You mentioned the case series, right? And I agree, right? They're not as valuable. But here we are, you've been talking about this for 10-ish years, right? This low carb movement, we'll call it, right? The revitalization of low carb. It's been a thing for a good decade now. It's interesting to me that I'm not aware of any case series on patients on low carb diets that have had heart attacks. Right? There are certainly enough detractors out there that if this existed, I would think one of them would want to say, hey, look at this. I found 3 of these guys, right?
There is one. There's one that was published in JCL. And it actually was the first mention of lean mass hyperresponders. But the irony is it was around 5 people. It was self-reported, so I don't know for sure, but it included the main person that was highlighted was a female who developed eruptive xanthomas. However, she was hypertriglyceridemic.
Right.
Super, super high levels of triglycerides. I want to say like 500, 600 or something like that. And
so not a lean mass hyperresponder.
No, I wrote them, and I thought with JCL, well, this is my first introduction to the world of journaling, because this is before I published a single paper.
Yeah.
And they said in the editorial or the case series, they said run by an engineer. This cholesterolcode.com is run by an engineer. And I was like, oh, they're specifically referencing me. They're referencing the site. So just like I would expect a newspaper, I can write a letter to the editor representing myself and, my thoughtful response. And I did that. I wrote one out. Had, I want to say, 13 citations and a whole bunch of other. We were pretty proud of the work. Submitted to them, and they flat out rejected it. Even though their case series referenced me, and they do have letters to the editor as an available. And it was, I want to say, 450 words or something like that. But that was one of the things I pointed out. Was I said, actually, this is not indicative of a lean mass hyperresponder. This phenotype is you're wanting to describe. And it's very relevant to specifically keep all of these lipid values together. There's a reason to not just look at high LDL in isolation.
Right. Because
it can be high LDL, like this woman who had very high triglycerides because it likely was poor metabolic health. The cool thing about looking at high LDL alongside high HDL and low triglycerides is, by definition, it is almost certainly going to be somebody who's metabolically healthy. And it's common enough that in the low-carb community, at the time that I was publishing that in 2017, I was like, I don't actually even know if I'm right on this. Like, it could be a whole bunch of people come forward who are, struggling with obesity, and they're like, oh no, I have this profile. It doesn't apply to lean folks. No, actually, it's pretty much almost universal.
I think the the kind of strict criteria that you laid out initially, I do find that applies, right? I do see not, I think there's a hyper responder spectrum. And I think I do fairly often see non-lean people who have not quite as dramatic, but a significant rise in their LDL.
Right.
But their HDL isn't quite as high, or their triglycerides don't get quite as low. More so on the HDL. It's interesting, right? The HDL really seems to maybe be the predictor of that, how responsive they are. In terms of their LDL. Because, I see people who get pretty low triglycerides, right, down into the 60s or 70s, but their HDL is maybe only in the 40s to 50s as opposed to in the 70s to 80s. And they get this hyper response, but I don't see their LDLs go up to like 600 or 700. Right. They go up to 200 or 250, and it's interesting to... and I know you've talked some about this, but, how much of this is a sort of genetic predisposition, or maybe it's not genetics, maybe it's that, history of leanness, right? Because it's interesting thinking about people who are relatively lean compared to what they used to be versus people who are truly lean.
Right.
Yeah.
So I have two thoughts on that. One, it is kind of amusing to me because for a while, I think a number of detractors to the research were saying, oh, it's genetic, and it's actually quite rare. And I feel like more and more of those folks have kind of dissipated somewhat. I think that there's more of an acknowledgement that indeed, if you are very lean and you go very low carb, it's more likely than not that you'll develop this triad. It may not be perfect lean mass hyperresponder cut points, but to what you were saying just now, the higher LDL, typically with modestly higher HDL and low triglycerides, depending on where they came from. So if it's somebody like, say, Dr. Tro, who quite literally was going from morbidly obese all the way down to lean, there's this period of time I sometimes like to call the lipid honeymoon. I don't know I have a theory behind it, but I'll talk about that in a moment. But for a while, their LDL tends to be lower. And in the case of Dr. Tro, it was, I want to say even 80 for a little while. And I said on Twitter, he and I were kind of arguing and talking back and forth, and he was insistent that, no, somebody doesn't have to have high LDL. And I myself am not on any medication, and I'm down to 80. And I said, I predict that you're in this kind of honeymoon phase, and that ultimately your LDL will start going up and will actually start climbing to levels that you're telling me here on Twitter you're going to be uncomfortable with. Because he was much more lipid hypothesis centric before. And somewhat famously, it did. It started creeping up substantially, and he was quite uncomfortable with it. What I think is going on, this is my hypothesis, I think that there's just greater remodeling of adipocytes that for people who are morbidly obese is some unknown span of time depending on what their adipose tissue is like.
Right.
So as you may already know, if you go to somebody who's metabolically healthy and has never been metabolically unhealthy, they're going to have a whole bunch of small adipocytes. They can, they've got hypertrophy, they've got hyperplasia to where they can make small little baby adipocytes pretty easily. Conversely, hypertrophy is where there is an adipocyte that's like, it's
gross,
too large.
Yeah.
It's metabolic itself internally is metabolically unhealthy and is even potentially dying, and it can even die. And there can be macrophages that come to attend to it. And in somebody who's been morbidly obese for a while, they often have a lot of dead macrophages scattered throughout their adipose tissue. It's basically a long triaging of your immune system trying to deal with all of these sick adipocytes all over the place. So some amount of your regaining your metabolic health, of course, is not very overnight. It requires getting that whole adipose landscape back into gear. And that almost certainly has some impact on your lipid profile. And I think, I still maintain this, but I don't know how much I'm going to prove to be right on this. I think that a lot of times cells that are in need, particularly depending on what their enzymatic capabilities are endocytosing ApoB containing lipoproteins because they can use them. For example, for their lipid bilayer, for things like structural repair, right? Again, I don't know how much this will turn out to apply, but the engineer in me is excited by the prospect, right?
You mean that we might make ApoB containing lipoproteins for some beneficial reason, and it's not just trying to kill us?
It's a thought. It's fascinating because
yeah.
This is quite literally how Brown and Goldstein found it in the first place. Is they saw, hey, in some cases, a cell intentionally takes up these lipoproteins, and that got them into the LDL receptor and a whole bunch of other things. Again, I hate to keep invoking it, but Engineer Dave is like, why would we do that? Why would we transcribe these receptors whose purpose is to have a binding domain to attach to the ligand of these lipoproteins by design. I want to understand that better. I want to understand why we do that. Why do inflamed endothelial cells upregulate receptors to then bind and transcytose LDL particles into the subintimal space? Like the nucleus is drawing up these plans in the mRNA, sending them out, getting the ribosomes to do, they're expending ATP to make all this very elaborate system happen to make these vesicles that then transport it. Philip, come on. There's a playbook in place. How much of this is by design versus by accident? Because as I was coming into this field, it was by accident, and only in 2020 did the same EAS group that gave us the 2017 consensus on LDL causes atherosclerosis make the mechanism paper, where there's that acknowledgement. And then you had a whole bunch of people acknowledge that the transcytosis could be a relevant piece of the puzzle for atherosclerosis. But again, that's an active system, not a passive one. And that's kind of relevant to this larger picture.
Yeah, I mean, and again, getting back to sort of the, what do I wish to see as a clinician? It's that, study like yours and the data and all of that at least gets us to the point of admitting that we haven't fully explained heart disease. An LDL, ApoB, whatever you want to say, right, isn't the full explanation of heart disease. And what can we do to have an even greater impact ultimately on it? And that's the only way we're going to do that is if we take these blinders off that have literally been on the heart disease community for the past 40 years, that we figured it out. It's LDL, ApoB, and we just need to reduce it harder, reduce it earlier, reduce it more, and that's going to solve the problem when clearly it isn't working out that way.
Yeah, it's just whatever. It's a process, and we'll get there. All right. I think this is a good place to wrap. Philip, how can people find you?
iFix Hearts everywhere. All the social medias. Go to ifixhearts.com, and that's where you can find me.
Well, thank you for coming on. I've been so excited for this one, and I'm glad we finally got a chance to put you on the podcast.
Love being here. Thanks, Dave.